Her roots in extension began with when her mother enrolled her and her two younger brothers in the 4-H program under the leadership of the late Miss Ruby Ragsdale, Anderson County Extension agent. She received a 4-H scholarship to attend Prairie View A&M University in 1973 and majored in home economics education with plans to become a county extension agent. She graduated in May 1977 from Prairie View with a Bachelor of Science degree and started her career as an extension agent with the Texas Agricultural Extension Service, now known as Texas A&M AgriLife Extension. In 2011, she assumed the role of Associate Administrator, where she has administrative oversight of extension agents and specialists in 35 Texas counties. She received a master's degree in 1991 from Prairie View A&M University and also her doctorate in agricultural education from Texas A&M University in December of 2000. She is married to Reverend Elton Williams and enjoys helping people reach their potential. She is also a gospel musician and singer. Without further ado, I'd like to kick it over to Dr. Carolyn Williams. Thank you, Dr. Williams.
Good morning, each of you, and thank you, Brian, for that introduction. You could have cut it anywhere. But anyway, we're grateful to be here today, and I really want to echo my thanks again to this committee. This is a truly passionate committee who loves people, it's obvious. And it didn't take them long to do what you're seeing today. I think it was maybe 2.5 months that we've come together and designed such an agenda that provides information and resources at such a time that we find ourselves in. Who would have thought that 2020 would have brought us to this level of crisis and uncertainty? But what I am grateful for is to be a part of an organization, especially the Extension organization, who has a great history and reputation of linking other agencies together to address needs. Those that we cannot solve, we try our best to. But I'm grateful to be a part of an organization that is intent on helping people help themselves. You will find today some of our great speakers and resources that will be shared to help you as well as your clientele, your neighbors, your family, because the fact is we all need each other. We have great resources, we have great expertise to share, and if we're not doing that, shame on us. I love being a part of USDA. I've been a part of this organization over 40 years, and to see the amount and the passion and the vision that the leaders take such pride in to make sure that information is shared, information is disseminated to the people who need it the most. So I want to just welcome you and ask you to just really take advantage of all the information that you will receive today. Take care of yourself so that you can better take care of your family. And my heart right now is very heavy because of what's going on with the families in El Paso. So we are the hope.
The staffers on today's call.
Working together, we are the
I would
hope
like to take a
that
moment.
can help turn some of the issues around and address some of the issues to help our families. So thank you, and have a great discussion, roundtable discussion today.
Thank you, Dr. Williams and Mr. Zolko, especially for your support in planning today's event. Now we begin with our first session on mental health and COVID-19, featuring Ms. Carla Geiss and Dr. Erica Nason. I'd like to start by introducing our speakers. Ms. Geiss is a licensed professional counselor, supervisor. She has been working with adolescents and young adults suffering with mental illness, behavior disorders, and substance abuse issues since 2006. Mrs. Geiss earned her Master's of Education Counseling degree from the University of Houston, Victoria, and a bachelor's degree in broadcast journalism from Buffalo State College in Buffalo, New York. She currently serves as the Assistant Director of the Student Counseling Services at Prairie View A&M University in Prairie View, Texas. She also has a private practice at Houston Psychotherapist Incorporated in Cypress, Texas. Her areas of expertise include crisis management, prevention, programming, and educational counseling. Dr. Erica Nason is a clinical psychologist and assistant professor in the School of Social Work at Texas State University. Her primary area of expertise is in understanding and treating reactions to stress and trauma. She is currently the principal investigator on a USDA National Institute of Food and Agriculture funded project designed to train mental health advocates in rural and agricultural communities. Without further ado, Dr. Nason and Ms. Carla Geiss. Mrs. Geiss, can you hear us? Ms. Geiss, you're unmuted, but I don't hear you. Dr. Nason, would you like to start?
Sure, I can start if that's helpful. Okay, so originally we were going to start off with Ms. Geiss delivering just some overview of the prevalence of mental health problems. And so what we know broadly is that the experience of mental health symptoms such as depression or anxiety truly are more normal than not normal. So lifetime statistics suggest that 1 in 2 individuals will meet a diagnosable criteria of mental health symptoms at some point in their lifetime, which means that if we weren't social distancing right now, if we were all in a conference room someplace, we could look to the person to our left and look at ourselves, and one of us at some point would experience a diagnosable mental health disorder. And having said that, if we move to the next slide. The question is, if we look at individuals who are worried about their mental health, so individuals who have insight that they might be experiencing symptoms that are at the threshold where they could use mental health assistance of some sort, whether that be in the form of formal treatment, group therapy, some sort of support. We know that of those individuals, over half do not actually go on to seek mental health care. And it's important to begin to understand why this might be. And move to the next slide. One of the primary reasons might be related to stigma and our beliefs about mental health care. And so I know that we're meeting over Zoom, and it may be difficult to kind of interact in ways that we might if we were in person with one another. But I wanted to start with a brief sociocultural exercise and just thinking about where our beliefs about mental health come from. And we could potentially use the chat box for this if people want to kind of type stuff in and throw it out there. And I know that we have kind of a mixed crowd today. Some of us are mental health professionals who have lots of training in this area, and some people are professionals in other areas who might be less familiar with mental health or might spend less of their day thinking about topics related to mental health. But I think it's worth just reflecting on both personally and within our communities. Where do our beliefs about mental health tend to come from? What are the sources that kind of contribute to our understanding of mental health broadly? And then what biases might exist in some of those views that are related to mental health? So thinking about perhaps some of the myths associated with mental health stigma. And I'm seeing a couple of comments in the comment box. So for family experiences, also from TV, media, and movies, absolutely. Our family, our communities, these all tend to be places where our mental health beliefs are formed or influenced. So if we grow up in a family where mental health is not talked about or is viewed as perhaps weakness, that might change how we respond to mental health symptoms in the long term. The same goes with community. Friends absolutely are an important resource, especially we know that friendships and social supports in adolescence are really, really important. And we also know that that's a period of time when people are likely to begin experiencing mental health symptoms for the first time. So those influences of friends can be absolutely very important. And we'll talk about actually peer support a little bit this morning as well. What are biases that people have experienced or are aware of related to mental health? So thinking about these sources, the TV, media, family, community, what sort of messages do we often receive about mental health? Mental health is not treatable. Absolutely. This is a really big one, right? So the idea is that it won't matter if I get treatment or not, because nothing's going to be able to help the experiences that I'm having. Are there others that people can think of as well? Mental health makes individuals dangerous. And this is one I think that absolutely is perpetuated in the media every time we have an incident of kind of mass violence, school shootings, things like that. It's often pinned on mental health diagnoses as opposed to other factors. People are crazy if they have mental health symptoms. It's the individual's fault. They should be able to control it. These are all absolutely things that we hear. Only weak people have mental health issues, so it's a moral failing. So these are largely some of the myths that we are coming up against when we're talking about stigma within our communities that oftentimes create a pretty substantial barrier for people being willing to talk about what their experiences are and being able to reach out for help. You don't have faith if you're experiencing mental health issues, absolutely. Thinking about how these beliefs might affect behavior and teasing out both for your own behaviors towards mental health and others, because we oftentimes treat people differently than we treat ourselves. So if I'm experiencing mental health symptoms, maybe these messages are louder or resonate more strongly for myself. But if I came across a loved one who was experiencing mental health symptoms, maybe I'd experience more empathy. Maybe I'd be more likely to encourage them to seek help. Or it could be the other way around. So sometimes thinking about kind of how our own behaviors towards our own mental health versus our behaviors towards others might be helpful. And then it can also just be helpful to think about what types of facts about mental health are you unaware of? And hopefully, as we kind of move through today, some of that will be highlighted. But it can be a way of reflecting on other kind of blind spots that might contribute to our biases. And we can move to the next slide. So you guys kind of nailed a lot of these myths that I had kind of preloaded on here as you guys were joining in the chat. So I really appreciate that. So there's an idea oftentimes that mental health symptoms are uncommon, right? If we don't discuss our experiences with mental health symptoms, oftentimes we can kind of think about this as being like an iceberg where we might only see the tippity top of what people's experiences are. And underneath there could be all sorts of things that we don't actually have access to that they're experiencing in a private way. And so if people aren't willing to talk about their own experiences with mental health symptoms, this is one of the ways that we can kind of perpetuate some of these stigmas in our communities. Mental health symptoms are untreatable, which we have many, many very good research supported treatments for all sorts of mental health symptoms. They're the result of moral weakness, and then sometimes a self-other bias. So we tend to perpetuate, overestimate the likelihood that other people will experience difficult things than ourselves. And so the idea that maybe other people will experience mental health symptoms, but this isn't something that would happen to me, or this isn't something that would necessarily apply to me. We can move to the next slide. When we're thinking about agricultural communities or rural communities, there are also a number of other kind of factors that we want to think about, and that can make the mental health needs of these communities unique. And of course, we're in unique circumstances right now where some of these are going to be exacerbated even beyond what they typically are. Oftentimes, these communities experience stressors that are outside of their direct control. We know that external stressors or stressors that feel outside one's locus of control can be associated with higher levels of distress or powerlessness. So things like experiencing drought or weather patterns that can affect crops, tariffs affecting profit margins, things like that, the ability to sell, pests, all of those are things that can occur and occur frequently, but we have limited control over. Exposure to things like traumatic events, drought, or weather patterns that can affect crops. These are tariffs, kind of unique experiences within these communities. And then rural communities often simply lack mental health resources. So we live in a really, really large state. 183 counties in our state do not have a single practicing psychiatrist. And so it can be really difficult, even if you do kind of want to seek treatment for mental health symptoms, it can be difficult to find a place to do that. Social isolation, this is something that has only been exacerbated by COVID-19. So as many individuals are social distancing or not participating in person in workplaces or at school or things like that, we know that social isolation has become kind of an increasingly important factor over the past year or so. And then some important cultural considerations. So attitudes about mental health within rural communities, in particular an emphasis on self-sufficiency and independence. So these attitudes are strengths in many ways, but they can also contribute to some of the stigma about mental health. And if I expect that I should be able to kind of take care of my family and myself, I might again be less inclined to seek mental health treatment. And next slide. So we often talk about risk factors associated with mental health, but I think it's also important to talk a fair amount about resiliency. And this is in part because we often have a little bit more control over building resiliency or building up resources that can be protective around our mental health. So we know from research that resources and skills can be practiced and can be developed that can help us to develop resilience or to adapt positively to more significant challenges in our lives. If you want to, next slide. So a couple of factors that go into building resilience, being more flexible with our thinking. So instead of kind of viewing things as black and white, really kind of thinking about the world around us in a flexible way. So this is certainly a skill that can be built. It's something that's focused on a lot in cognitive behavioral therapy in particular, but being able to kind of play devil's advocate with a thought or entertain alternative explanations for experiences that we have. This can be especially illustrated by social interactions. So if we've probably all had the experience of a social interaction where we thought somebody might be kind of reacting to us in a strange way, or maybe we're being rude, but come to find out later, maybe they just received some bad news or things like that. So being kind of flexible in our thinking about the world around us, developing good coping strategies, and this includes both developing self-care routines in the absence of stressors, But then when things do come up, being able to kind of cope in healthy ways that are helpful in the long term. So for example, using alcohol or drugs can be helpful in the short term. It can make us feel better immediately, but those tend to be strategies that aren't good long-term stress management approaches. Thinking about leveraging social supports, this could be family, peers, colleagues. There's actually really good research suggesting that peer-to-peer support related to mental health is something that can be helpful. It can be helpful in the short term. It can make us feel better immediately, but those mental health interventions, so being able to kind of have somebody to talk to about mental health concerns is a key piece of this puzzle, we think. And then reducing biological vulnerabilities. So I teach at Texas State University. I always use the example with our students around finals week, where oftentimes our students are not taking good care of their biological needs. They're probably not sleeping very well. They might not be exercising like they usually do. They might be living on frozen pizzas. And so those biological vulnerabilities absolutely can contribute to some of our own kind of likelihood of experiencing psychological vulnerabilities. Those tend not to be the times when we are able to cope most effectively. And next slide. So thinking outside of the box, I just wanted to talk a little bit about mobile applications that are available for addressing some of these mental health symptoms. And these are really nice for a variety of reasons. So some of the strengths are that, you know, most individuals have access to a smartphone. They've kind of become fused to our hands these days. And the mobile applications, most of them are free related to mental health. So they are pretty accessible, even in communities where there might be barriers like not sufficient mental health providers. Many of them are based on good research, so they take kind of what we know tends to be most helpful for addressing anxiety or depression symptoms, and put them into a mobile application. They're really discreet, so if you're sitting in a waiting room or if you're killing some time, and pull out your cell phone and start using one of these mental health apps, nobody else in the room necessarily knows, right? That can be destigmatizing. We all kind of have a tendency in our society to pull out our phone when we're killing time. So there are some real strengths associated with it. A couple of limitations is, you know, it probably requires some broadband access, at least to download initially. So that might be a barrier, and anyone can create an app. So while there are really, really good ones out there, if you just kind of go in and search randomly, you might end up with an app that isn't really based on research or doesn't have as many helpful tools embedded within it. Just to give an overview, many of the mobile applications that are available have a combination of psychoeducation, so teaching about what mental health symptoms are, what we know about kind of what helps them develop or be maintained in the long term. The emphasis is often on teaching skills. So we'll take a look at an app that actually came out at the beginning of the pandemic and do a little bit of a deeper dive there. They can help track behaviors, and this is true about both kind of symptoms that people might be experiencing, but also tracking behavior changes, so things that people might be doing to cope more positively. And we can even set reminders or motivators within the apps to kind of remind us to engage in some good practice. And we can move to the next slide. So COVID Coach is the name of the app that came out. I want to say it came out as early as March. It was distributed by the Department of Veterans Affairs and developed by a team there. And they really, really did kind of push this out very, very quickly, recognizing that mental health needs were likely to be increasing as the pandemic developed. And so the COVID Coach, one of the things that's really, really nice about it is that it is pretty broad in the types of symptoms that it addresses. And it's available for free for both Apple and non-Apple devices. So it is generally kind of designed to build resilience, manage stress, and increase well-being during what we know is a crisis on many levels. And there's kind of a summary of some of the features, but if we just keep moving, I'll actually show you guys some of the snapshot or some of the screenshots and some of the features that are embedded within the within the app itself. So this is just kind of a screenshot of the opening interface on the far left. So it gives you kind of a nice menu. It's very aesthetically pleasing. It's easy to use. It gives you a menu of options. It also gives some instructions to the user about the best way to use the app. This is something that could certainly be used in conjunction with formal psychotherapy or formal mental health services. But for individuals who are experiencing lower levels of symptoms, it might also be possible to use this independently and kind of manage stress a little more effectively. And if we move to the next slide, there should be some of the features. So you see if you kind of select each of the different options, it again kind of expands a menu. So within the manage stress option, for example, there are meditation options. There's an opportunity to set a daily schedule or ritual. There's also meditation, such as doing a body scan. There's an opportunity to learn information. So the app will provide information about how to stay balanced for an individual, things that can help an individual to stay well overall. There's some nice mood trackers embedded right in the app as well, so people can kind of look at progress over time. Oftentimes, if we are changing our behaviors to kind of build resilience, progress is slow but steady, and so it can be helpful to kind of track that over a longer period of time. Otherwise, we might not even be aware of some of the effects that the changes we've made have been having. And then there's also a really nice find resources aspect of the app, where if people are kind of noticing that perhaps this isn't sufficient, this is a way of potentially putting them into contact with additional resources that could be used as supports. And I think next slide. There's ways to be logging feelings. So this can be a nice way of kind of looking at a more nuanced way. So it starts with kind of broad emotions such as sadness. Like that, you can kind of within that even narrow in on certain elements or aspects of the mood. So are you feeling bored? Are you feeling lonely? Are you feeling tired? What is that like? And this helps individuals to potentially be making connections between certain types of environmental or day-to-day experiences that might be influencing their mood. You can rate the intensity of your distress and then provide kind of these summaries of the emotional experience. So another way of tracking. Oh, there's a question about, is it bilingual? Can the settings be changed to Spanish? I am not 100% sure about that, and it is a really good and important question. I can check on that and get back to people later in the day. This app could be appropriate for adolescents or teens. I think it does a really good job of kind of breaking things down in pretty simple, bite-sized ways. Another app that I think has been tested a little bit more with teenagers is something called a virtual hope box. This is an app that was developed originally for suicide prevention, but has some broad skills and allows people to kind of upload pictures or upload resources that can help improve their mood. So virtual hope box might be another one to think about for teens, even if they're not primarily experiencing distress related to suicide or suicide risk. It also has some tools that can be generally helpful in building resilience. I appreciate those questions. And we can move, I think, to perhaps the last. The other app is Virtual Hope Box. I will type it into the chat right now. As far as accessibility to those who have sensory disabilities, again, I'm not totally sure. Those are really good questions. I will look into those and try to add them to the chat box later this morning as others are presenting, perhaps. So mood check, these are just kind of additional examples. The last one all the way on the right is kind of an interesting one. So for people who are experiencing anxiety or find that they're worrying throughout the day, a skill that's sometimes counterintuitive is actually setting aside time, about 15 minutes or so, that is explicitly flagged for worrying. And so this is kind of a forum for doing that within the app itself. And so by kind of focusing that time and kind of processing those worries, it's possible that people might experience less of the intrusiveness of the worry or anxiety throughout the rest of their day. It kind of gives them an outlet for processing some of those thoughts and worries. And next slide, I think that might be my last slide, actually. Yeah, so my contact information is available right there. If anyone has any additional questions, I'm happy to be reached at any time. And I appreciate everybody being here this morning and the opportunity to talk a little bit with you all.
Thank you, Dr. Nason. And I believe Ms. Geiss was able to get on. Ms. Geiss, can you hear us?
I can hear you. Can you hear me?
Yes, we can hear you.
Anything's possible with the Zoom in the morning.
Well, there are your slides. Thank you so much.
Thank you so much. And thank you, Dr. Nason. That's a great lead into what I'm going to be talking to you all about, and that is mental health and COVID-19. Let's go to the next slide. And since we're talking about mental health this morning, I'd like to begin by asking everyone a question this morning about how you're doing. We talk about how everybody else is doing, but I think it's very important that we check in with each other and see how we all are doing. So I'd like you to use the chat box real quickly and think about the pandemic when it first started and then how you're feeling now. And in one word, describe how you're feeling at this particular time as it pertains to COVID-19. What's one word if you could use to describe? Hopeful, restless, resilient, concerned, worried, anxious. Absolutely. Absolutely. Thank you so much for those responses. And as a matter of fact, those responses pretty much line up and they're consistent with what everybody has been feeling basically around the country. When you start thinking about the concerns that everyone's having around the country, most of the responses are worry, concerned, tired, hopeful, exhausted. Those are the words that are used to describe how everyone is feeling. And when we really think about it, we've been dealing with these feelings and these emotions for 9 or 10 months. And we as professionals, and I know we've been talking about professionals being in our audience, we know that when you're dealing with these particular feelings for a long period of time, that they can weigh on us mentally. And so that's what we're going to look at today, is how all of this is impacting each and every one of us, but also our community at large in our mental health. So I'm just going to chat about a couple of things. What is mental health? I think it's really good to have a working definition, the current state of the mental health here in the US, taking a look at the impact of COVID-19 on our mental health and what we can expect as mental health providers. We know that when you're dealing with and the community at large, and then our call to action overall. Next slide, please. And so our working definition for what is mental health includes our emotional, psychological, and social well-being. It also affects how we feel, act, and think. And it also helps us determine how we handle stress and how we relate to others and basically how we make choices. One thing for sure, when we think about mental health, our overall well-being can be disrupted by biological, psychological, physical, and environmental factors such as the pandemic that we've been experiencing. And all of this can lead to mental illness. And so when we talk about mental health, it's very important that we understand that there's a difference between mental health, the term mental health, and the word mental illness, but they do intersect. If our overall well-being is compromised, mental health well-being is compromised, it can lead to a mental illness. And so mental illness includes a lot of different conditions that can range from various degrees of severity, from mildness to severity. It could be any mental illness, or it could be a severe mental illness. Next slide, please. So I'd like to begin with a little bit of background before we jump into the impact of COVID-19 and what we're experiencing with our mental health by just talking a little bit about what we knew before COVID-19 began. And so the National Institute on Mental, in 2019 gave a report, and this is consistent with some of the other reports around the country, that 1 in 5 adults is diagnosed with a mental illness. And so when we really take a look at that in 2019, that meant an estimate 51.5 million adults ages 18 and older in the US was diagnosed with any mental illness. And that could be anything from depression to bipolar to schizophrenia. That's more of a serious one, but to any mental illness. And so that represents about 20.6% of all US adults. And so it's very important that we have a good understanding and a picture of what we were dealing with before COVID-19, because now we want to look at how our mental health has been shaping up since all of that has happened, and taking a look at also we individuals struggling with, and now we have a new additional individuals struggling with mental health, and those who were already diagnosed with a mental illness, struggling with their mental health. They were more vulnerable at that time, but even more vulnerable at this particular time with COVID-19. Next slide, please. And so having a good understanding about what our current picture on mental health looks like right now, since the onset of COVID-19, there's been an increase of a number of individuals reporting various symptoms consistent with mental illness, such as anxiety, persistent anxiety, depression, stress, worry, behavior concerns, increased substance use. All of these continued reports and over a long period of time can compromise our mental health. And one thing for sure that this pandemic has done, it has elevated mental health into the spotlight and has prompted the health agencies and organizations to investigate and pay closer attention to our impact, to how COVID-19 is impacting our mental health. And I know as a professional working at the university, we are constantly having students coming in and talking about some of the symptoms that I just described and how it's related to how they've been feeling this semester. We're seeing that increase of students reporting anxiety, talking about feeling depressed, stress, and a lot of this is related to a lot of the things that are going on with COVID-19 and some other conditions that we're experiencing here in the country. And also one example of a report that was just released by the American Association for Pediatrics. It's a report that just came out, and it talks about an increase of family problems and behavioral problems with children. And also something that was very astonishing to them is that there's been an increase in the number of children being that are presenting at the ER, the emergency rooms, with mental health concerns. And that just kind of gives you a picture of what we're looking at. And so I've taken a look at some research by the Kaiser Family Foundation, the National Institute of Mental Health America, and the CDC, because each of these organizations and agencies have been tracking our mental health over these last 9 to 10 months and have been reporting on what they have been finding. And some of the things that they're finding that's being reported are consistent with a lot of the things that you just mentioned in here, how you've been, but they're also noticing is that this is going on and it's long term. And so the concern is now, what will this mean for us, not just short term, but how is it going to impact our mental health in the long term sense? Let's take a look at some of the research that was done that they're finding that's being reported are consistent with a lot of the things that you just mentioned in here. And so I'd like to just take a look at this one right here. So this is the effects of COVID-19 on mental health, and each one of those agencies pretty much identified these three areas as the areas that individuals have been struggling with the most. Isolation, and when we think about isolation, we're talking about social isolation, our ability to interact with each other. That could be family members, that could be friends, that it could be even coworkers, college classmates. When we're on the college campus, our students now are very restricted, even students in their not undergrad students, but children being able to go to school and interact with their friends. That's part of that isolation. So isolation, especially on our elderly individuals, can be linked to poor mental health and physical health. So that was one of the effects that we've been noticing that has had one of the greatest impact. The next one is job loss and income insecurity. And right now, this is a big concern, especially with us beginning to see increases in COVID cases again around the country. Several states looking at shutting down again, places looking at closing again. What kind of impact is this going to have? Because already we've noticed that the job loss is associated with increased depression. More individuals are reporting anxiety, distress, and it also leads to low self-esteem. And it may even lead to higher rates of substance use, because there's we're looking at how can we cope with all of these particular feelings and these new situations that we're experiencing, and everyone copes with stress differently. And so everyone doesn't have the exact same skills to manage all of these stressors. And we do know that when we experience a pandemic, that it is a very stressful situation. And so this is some of the fallout from the isolation and job loss and income insecurity. And then we have the increased burnout from frontline and healthcare workers. That's a major, major concern. Basically, our frontline workers, our healthcare workers, they are experiencing long working hours, continuously being exposed to trauma, so they can receive secondary trauma. So we're getting reports that are saying that there's an increase in anxiety and mental illness among those, and even for poor physical health concerns when we're dealing with our healthcare workers. And we as mental health workers, we also have to make sure that we're taking care of ourselves as well. Next slide, please. And so taking a look at what the Kaiser Family Foundation reported, and they've been tracking the mental health of the country since the onset in March. This is just a few of the findings right here, that they conducted a poll from mid-July all the way through until September. So this is just a little bit of what they have discovered. 53% of adults in the United States reported that their mental health has been negatively impacted due to worry and stress over the coronavirus. And what is interesting is this is significantly higher than the 32% reported back in March. So at the onset, only 32% of individuals reported this, but as it's been going on, you're seeing that increase of individuals experiencing more stress and worry. And this was a question they presented at the early onset. And then also, as you start looking at our overall well-being, many adults are also reporting specific negative impacts on their mental health and well-being, such as difficulty with sleeping. How many of you are having difficulty sleeping? Thinking about that. Eating, having difficulty with eating. Increase in alcohol and individuals experiencing more stress and worry. The other thing that they reported, that 12% of the individuals at the early onset, and then also as you start looking on worsening our overall well-being, so you're already experiencing any physical conditions. We know sometimes stress can manifest, worry can manifest within your body. And then another 12% reported that their symptoms were worry and stress over the coronavirus. And so these are some very interesting results from their report. Let's take a look at how this plays out. Can we go to the next slide? So this is just a graph right here that just kind of shows you what we were just talking about. If you take a look at this, it talks about the average share of adults reporting symptoms of anxiety and depressive disorder during COVID-19 from May to July of this year. If you notice on here, pay attention or take a look at in May, it talks about if you notice the light color is the anxiety disorder was at 29.6%, And then at the end of May, when you start looking at the symptoms of anxiety or depressive disorder, it was at 34.5%. But if you jump all the way to July, notice the increase in depressive reports of anxiety and the reports of depression. For anxiety disorder was at 35.2%. Notice back in May was at 29.6%. So you notice that it's continuing to go up. And then at the end of May, when you start looking at the symptoms of anxiety, either anxiety and depression or both, in May it was 34.5%, and in July 40.1%. So the numbers keep going up, and that's consistent with what we know as mental health professionals, that the longer we're exposed to a stressful situation, the more it impacts our mental health. Let's go to the next slide. And this is something that is, I put in here because I think it's very interesting, and this kind of lines up with what we've been looking at when we talk about how the COVID-19 has disproportionately been affecting individuals, from those who are healthcare workers to those who are more low income. Interesting information. This was a survey done, and this is about adults who say they worry or are experiencing stress as coronavirus has had a negative impact on them. And this is according to household incomes. And this is their survey, and their research shows those who make less than 40% had a major impact, reported major impact of negative symptoms at 35%, or either a minor at 23%. But if you jump down to those who make 90,000 or more, you could see that it was only 20% that reported that that they were having it was having a major impact on their mental health, and 32% reported that it had a minor impact on their mental health. So that's really consistent with what we've been hearing and what's been reported when it comes down to the disproportionate amount of how the coronavirus is affecting individuals disproportionately. Let's go to the next slide, please. And then the other most vulnerable group is our elderly. And so in their poll, they report that the percent of older adults ages 65 and up who say worry or stress related to the coronavirus has negatively impacted their mental health. You can see also from March, it was at 27%. And as we're getting into July, it increases. It almost doubles in their numbers to 47%. And so you can see this also lets us know what we're looking at as well with our adults and as well as our seniors. Next slide, please. And so Mental Health America has released their 2021 report on COVID-19 and mental health, and they call it a growing crisis. They're looking at adults as well as seniors, but I wanted to pay attention here to youth because they're very vulnerable right now also because of discussion that's going on. Should they be in school? Shouldn't they be in school? Should they be playing sports again, or shouldn't they be playing sports again? And we all know that all of that is needed for their development as well as their overall mental health. So their report from March to September indicates that over 80% of the poll that the individuals that they polled from 18 to 17, and let me just correct that. These are individuals that took the screening on Mental Health America's website. The youth, what they reported that their anxiety had increased by 84%. And that also said that 11 to 17-year-olds scored for moderate to severe anxiety, totaling 18,551 youth. And so in March to September of 2020, at least 90% of the 11 to 17-year-olds who took a depression screening scored for moderate to severe depression. And in September of 2020, 90% of 11 to 17-year-olds scored for moderate to severe depression, totaling 38,215 youth. And so we could see that they're also being greatly impacted by COVID-19 as it pertains to their mental health as well. Next slide, please. And so this is some more information on Mental Health America, and I encourage you to go on their website and take a look at their report because it's very informative, especially for us as healthcare workers and mental health care workers. This is their report that was a result from January to September of 2020, and it basically talks about the number of individuals that they screened for anxiety and depression. And what they found that was really interesting is the number of people screening for moderate to severe symptoms of depression and anxiety has continued to increase, which is not a surprise to us. It remains higher rates prior to COVID-19. In September 2020, the rates of moderate to severe anxiety peaked with over 8 to 10 people who took the anxiety screening, scoring with moderate to severe symptoms. And if we jump down and look down here, it talks about more people are reporting frequent thoughts of suicide and self-harm than has ever been recorded on Mental Health America's screening program since it launched in 2014. So that gives you a clearer picture of just how individuals are feeling since COVID-19 has invaded our space. Since the COVID-19 pandemic began to spread rapidly in March 2020, they said that 170,000 people have reported frequent suicide ideation. That's 37% of the people reporting thoughts of suicide more than half or nearly every day in September 2020. So that's another startling report that we have there. Next slide, please. And then last, taking a look at what the Center for Disease Control reports. And this I thought was very interesting because we're talking about how we are responding to COVID-19, but they're taking a look at individuals who have had COVID-19 and then how they are recovering and how it has affected their mental health overall. And so some of the things that they found that individuals are reporting, I've listed here some mixed emotions, some that includes relief, fear and worry about their own health or the health of their loved ones, stress from the experience of having COVID and monitoring themselves or monitored by others, sadness, anger, or frustration because friends or loved ones have fear of getting the disease from you, or even though you're cleared, an individual might be cleared, they're still afraid to be around others. And then there's the guilt of not being around, not being able to perform their normal work or parenting duties while you've had COVID-19. So there's a lot of different things that they have been reporting as well, worried about getting reinfected or sick again, even though you've already had COVID-19, and other emotional mental health changes. There have been some recent reports also where they're taking a look at the long-term impact of COVID-19 on our mental health as well for those who have experienced it. And then children may also feel upset or have strong emotions if they or someone they know has COVID-19, even if they are better now and are able to be around others again. And so that's something to look at as well. Next slide, please. And so what does this all mean for us as mental health providers and healthcare workers and the community at large? For mental health care workers, it means that we have to be more flexible in our delivery of service. One thing we definitely know, when at the onset of COVID-19, there was a major shift because we weren't sure of the disease would spread. So we weren't sure. And so a lot of mental health facilities had to change how they delivered service. Many had to move from face-to-face to telehealth services. That significantly impacted those who were already receiving services and those who are in need of services as well, especially those who were diagnosed with severe mental illness. And so it means, how are we delivering our services? Looking at different options for presenting our services, especially for those not just in the inner cities, but as well as those that are in the rural communities. Then paying attention to trauma-informed therapy, taking a look at how individuals are presenting when they're coming in for therapy, and then making sure that we're screening for the impact of COVID-19 on their mental health. So when individuals are presenting with specific symptoms such as anxiety and depression, making sure that we're asking those specific questions and how it relates to COVID-19. I know for me, I'm always asking our students, how are you doing with COVID-19, and how is this affecting your ability to do your work? So making sure that we're screening for how they're coping and managing with being in the environment that they're in, especially with all the different restrictions that are affecting each individual. Then as healthcare providers, assessing for secondary trauma, assessing yourself secondary trauma, be constantly exposed over and over again to individuals who are presenting with COVID-19 and even those who may succumb to COVID-19. And then screening for the impact as well of COVID-19, listening out for the things that individuals are telling you about their sleep habits, their eating habits, their anxiety, their depression, and how it's associated with dealing with the pandemic. And then referring for services, making sure that as you're hearing that you're also encouraging them to reach out for help, to get counseling services. And then practicing self-care for yourself, putting together a self-care plan for yourself, using some of the apps that Dr. Nason presented, but also sitting down and thinking about yourself and how am I caring for myself to make sure that my mental health well-being is being taken care of. And as a community, conducting our own personal assessments, asking yourself, how are you doing? How am I sleeping? How am I eating? How am I interacting with others? Am I able, if I'm not able to interact with others face to face, what other opportunities are there available for me to interact with others? How can I connect with others? Connection is so important, using our social media platforms to connect with others. And then questioning our family and friends, asking our family and friends, how are you doing? How are you doing? How are you handling? How is your mental health during this time period? And as Dr. Nason says, we don't always ask that question. We don't ask that question because sometimes we're not sure what to ask or how to ask. And then it also goes back to how do we view mental health? And so once again, the pandemic has thrust mental health in the spotlight. And so it's a very important question to ask, how are you doing? And then practicing self-care, once again, putting together a self-care plan. One of the self-care plans I like to introduce all the time is the PIES. P for being physical, remain physically active in some kind of capacity. I, intellectual, remain intellectually stimulated. Learn something new in your restricted spaces. Learn something new. Read, figure out some things that you can do, playing Sudoku or crossword puzzles or just puzzles overall, but remain intellectually stimulated. And then paying attention to your emotions, remaining positive, setting some boundaries for yourself, setting some limits, especially on social media. How much news am I taking in? How much am I being exposed to information about COVID-19? Limiting how much I take in so that doesn't impact your mental health. And then the S, which is your spirituality. How do I find peace within myself? Some individuals pray, some people meditate, some people practice mindfulness, practicing relaxation techniques. What is it that I do to bring myself centered so that I'm not continuously overwhelmed by the stress and of what is going on in the world? And then know the signs. Get as familiar as you can with the signs of mental health. I have a couple of resources in just a moment that you can turn to that'll help you be able to get educated on the signs so that you can not only take care of yourself, but also that you can make references to others, refer to others. And then get help. If you feel that you are experiencing these feelings of overwhelm, exhaustion, constant worry, constant fear, anxiety and depression, and it's not going away and it's interfering with your ability to function daily, then get help. Talk to someone, get help. And so if we can go to the next slide. So here's some mental resources, and this is my last slide. These are some mental health resources that you can look on their sites because they have a wealth of information. The Hawk Foundation for Mental Health has a plethora of information on you can get mental health resources and get help. Also the CDC. In fact, I love the site on the CDC on mental health because it has so much information on how to manage your mental health, as well as where you can find help. Then SAMHSA, the National Helpline, that number 800-662-4357. that number. They have a wealth of information. Mental Health America has a guide for mental health resources as well. You can get that for free off their website. The National Alliance on Mental Health, you can go on their website and take the national screening tool, and that'll help you also to determine if you need to get additional help. And then the National Institute on Mental Health as well. If you click onto their website as well, they have several resources as well. There's also Psychology Today, which I don't have that on here. If you do need a therapist on Psychology Today, you can click on their website and you can find a therapist. You can isolate for your insurance, your zip code, what you're experiencing, and you can find a therapist within your area. You can also, if you have insurance, you can look on your insurance website, or you can look on the back of your insurance card. And on that insurance card, there's a customer service number, and you can call them and they will send you that information. And then there's also several agencies that do provide a sliding scale as well. So when you click on Psychology Today, individuals will tell you if they provide a sliding scale, as well as sometimes they even provide pro bono services for you as well. Here in the Houston area, there's also Shield Bearers Counseling Center, and Shield Bearers also does a sliding scale as well. So you can click on theirs. And then there's Good Neighbor in the Houston area. They have several locations around the area as well. So those are some resources for you as well. And Shield Bearer, as well as Good Neighbor, they also have facilities out in the rural areas, such as in the Prairie View area, the area as well. So you look on those. What I really call Psychology Day, no matter where you live, you can go on that website and you can put in your zip code and you can find a therapist in that area. Many therapists today are offering telehealth services. And so there are services available. I also included on here for you the National Suicide Hotline number. That's 1-800-273-8255. And then there's also Text Hello. And Text Hello is another resource. It's a crisis resource as well. And they provide additional information for you to find for mental health services. And this is a population that I wanted to include this information for the Veterans Crisis Line, because our veterans also, we know, are very vulnerable during this time period. And so their number is 1-800-273-8255. And so here's my contact information. And once again, I'm with Prairie View A&M University, and I'm one of the counselors as well as the Assistant Director for Student Counseling Services. And so I'd like to personally thank you for this opportunity, and I'd like to wish everyone good mental health.
Thank you, Ms. Geiss, and thank you, Dr. Nason. I think there are a couple of questions in the chat box, and so we can, if we can respond to those in the chat box, I'm going to go ahead and move on to our next presentation or our next session. And it is on how food insecurity affects mental health. And so our first speaker is Velma Vega Hughes, who is a board-certified psychiatric mental health nurse practitioner and CEO of owner of Fig Tree Behavioral Wellness in Harlingen, Texas, treating the South Texas mental health communities. She is also the interim program director for the University of Texas Rio Grande Valley's School of Nursing Psychiatric Mental Health Nurse Practitioner Program, where she also earned her postmaster's psychiatric mental health nurse practitioner certificate. Who is a board-certified She is an alumna of the University of Texas Brownsville School of Nursing, graduated with her associate's degree in nursing in 2007, bachelor's of science in nursing in 2008, a master's of science in nursing in 2014, and a psychiatric mental health nurse practitioner certificate in 2016. She is currently in the Doctor of Nursing Practice program with Chatham University in Pennsylvania, where she is completing her capstone project in the relationship of vitamin deficiencies and depression. Having personally gone through postpartum depression, she knew that she could comfortably empathize with this fragile patient population. Mrs. Hughes?
Hi, thank you. Wow, thank you, Ruby. Well, my name is Velma. I think she's pretty much summed it all up pretty good. Thank you, Ms. Geiss. Those were wonderful mental health resources that you listed there. Okay, so if we start on next slide. My philosophy is the doctor of the future. Well, Thomas Edison had it right, I believe. The doctor of the future will no longer treat the human frame with drugs, but rather will cure and prevent disease with nutrition. When I treat my patients, I look at them holistically, mind, body, and soul. Many times, next slide, clinicians run to my philosophy is therapies. The doctor of the future. Well, Thomas Edison had it right, I believe. The doctor of the future, looking at the patient holistically first. The problem there is the side effects of medications. During my clinical training, I was often faced with my preceptors and asking them, questioning them, what was the reason or their rationale for medication administration instead of teaching on nutrition. And unfortunately, most of them said there's just no time, or the patient just won't understand. They won't follow a diet. I've noticed that when you talk about diet, a lot of patients get scared of that word. I know I do. I don't like the word diet, so you use the word nutrition. At least I do in my practice. So today it's about the connection between nutrition and depression, or the lack of nutrition and depression. Next slide. So according to the World Health Organization, some of the key facts about depression is that it's a common mental disorder. Globally, it affects 264 million people, worldwide, globally. And this is from all ages, geriatric down to pediatric. I treat patients as young as 6 years old. And most of those patients, the parents come in with a lot of complaints of depression and anxiety, and I'll talk more about it in the few slides ahead. It all really boils down, mostly boils down to nutrition. Worldwide, this depression is a major contributor with or a global burden of the disease. So since COVID-19, more children are affected, but why do you think more children are affected with mood disorders, depression, anxiety, ADD, ADHD? That I was wondering, what was the reason why more of these children school-age children were coming out with, more symptoms of this depression and anxiety. Food insecurity, go to the next slide. So nutrition, what's happening? So most of these nutrients cannot be manufactured in the body when they need to be consumed. So most of the nutrients, once you do consume them, they pass through the lining of your intestine, and then that's where it's introduced to capillaries. That's how it's introduced to the blood. But if there's no nutrients, then what happens? Although food is clinically or classically been perceived to provide energy and building material to the body, in particular, the ability to prevent and protect against the diseases that we're starting to recognize more and more with evidence-based practice. In particular, research over the past 5 years have provided it's really exciting evidence that influence of the dietary factors dietary factors on specific molecular systems and the mechanisms that maintain mental function is what we're recognizing. So nutrition has a lot to do, go hand in hand with mental functions. For instance, the diet rich in omega-3 fatty acids is gaining more recognition on, to help prevent Alzheimer's disease and to help support cognitive function and cognitive process. Next slide. So how does, let's see, I'm having a little bit of a malfunction on my side. Can y'all still hear me? Yes, okay. My apologies. Oh, my apologies. Okay, so how does nutrition affect the mood? Many of my patients that are referred come in with already diagnosis of these disorders. I have bipolar disorder, I have anxiety, I have depression, OCD, ADHD, and this is again from my pediatric patients all the way up to the geriatric patients. So since well, back on the initial evaluation, what I do is I get a blood sample, and it's routine just to rule out vitamin deficiencies, mineral deficiencies, iron deficiency, anemia, just things that maybe their primary care physicians or caregivers might have overlooked as a physiological dysfunction. I asked them about their sleep hygiene, their eating habits, sun exposure, because we know vitamin D is, we mainly get that from the sun. The sun helps our skin, produce the vitamin D. Since COVID-19, though, more and more children have been I guess you can say more children have been presenting with mood disorders, affective mood disorders, which include all of these above. A lot of times, it's because they're not in school anymore. They're not in their PE classes. They're not going outside, for their exercise or their, 45-minute or 1-hour PE exercises. Most of the school-age children that I've seen will admit that they're on the computer, most of the morning, and then they transfer out to their gaming. So, sun exposure just almost goes out the window. There's evidence linking between low vitamin D levels and depression. So high percent of patients that I've tested that come in with depression have a low vitamin D level. Now in mental health, we'd like the vitamin D levels to be slightly higher than what primary care physicians have ruled as as normal. Next slide. So the National School Lunch Program, what this is it's a federally assisted meal program that is in operation, of course. It's in public and nonprofit private schools and residential childcare facilities like daycares. It provides nutritionally balanced meals or low-cost meals, and even most of them are free, to 29.4 million children. This was back in 2019. It provides, their daily grains, their proteins, their vitamins, vegetables. And the program was established under the National School Lunch Act, signed by President Harry Truman back in 1946. And this is information that you, or I've got from the USDA website. So if these children aren't going to school, because of COVID, they're not receiving these meals that are nutritionally balanced. This is where more and more of my patients, school-aged patients, start asking them questions about how do they feel about food. And I don't say food insecurity, but how does it make you feel if you can't get your next meal? And a lot of them would say that they depended on meals coming from the school. So that was pretty alarming. Next slide. Okay, so how's COVID-19 affecting nutrition in children? So back in 2018, according to the CDC, 14.3 million households were uncertain to enough food. And this was 1 in 7 children. And of course, you know, like I said, this was back in 2018. So what, if we look at the statistics between then and now, of course, it's going to substantially increase because of COVID now. From mid-March through the end of June of this year, there was 49 million unemployment claims due to COVID or secondary to COVID. So if 1 in 7 children were struggling with food insecurity in 2018, you know, pre-pandemic, we can only imagine what it's like now. So nutrition, of course, plays a major part in the cognitive function for everyone, you know, not only children, but for everyone. Most kids were receiving a well-balanced meal, you know, at school. And it wasn't until recently, now in the fall, that 56 million children were able to return back to school. Some schools are now, you know, closing back up, getting a little tighter, so they'll be going, you know, back in homeschooling. Now, granted, schools started handing out these meals for these children that were homeschooled. The families were able to go and pick up these meals, but the parents that had no transportation or depended on the school system, the bus, you know, to pick up their children and drop them off, these meals weren't getting to them. Now, many of the low-income family or my low-income family patients do not have transportation. So this telepsychiatry that I'm doing now really benefits them. And I was able to engage with them and ask them questions about how homeschooling versus sending kids to school in regards to nutrition, how it was affecting them. And I did ask one of my patients how it affected him, and he said that he's 7 years old. He said that it would make him cry because he would see his mom cry about no food in the house. So that you know really punches you in the gut. Let's see, next slide. So if these families don't have transportation to go pick up, you know, these meals, much less do they have a vehicle to wait in line. So this past weekend, according to CNN, there was thousands of people lined up at the lined up for groceries at this food bank distribution event in Dallas, Texas. So this is, you know, the way I was talking to, you know, actually my husband last night, this isn't partisan, you know, this is health and wellness of families, friends, neighbors. So we have to ask ourselves, you know, are we doing enough? Or how could we do more? So using this information, we need to better design, you know, policies, programs, procedures to address both physical health, according to, you know, in regards to nutrition, as well as mental health, well-being, in aspects of food insecurities. So that way we can treat the patient more holistically to improve the health of the low-income populations. And the next slide. And then here I'll just close out with what Dr. Williams said this morning is, she opened up with, it was a quote, "Take care of yourself so you can take care of others." And I think that's extremely important. Is if we're not able to care for ourselves, we don't have the energy or the mental capacity to care for others. And I just want to thank you for the opportunity to speak today.
Thank you, Mrs. Hughes. We'll now hear from USDA agencies on some updates on programs on USDA's response and support to ensure that our partners are helping feed those most in need during the pandemic. So we'll first hear from USDA Food and Nutrition Services. Ms. Katrina Kamau is with the United States Department of Agriculture Food and Nutrition Service. She currently serves as the branch chief in the SNAP division of the Southwest region. The Southwest region covers 7 states, including Texas, Oklahoma, New Mexico, Arkansas, Louisiana, Arizona, and Utah. Katrina?
Thank you, Ruby. Good morning, everyone. Again, I'm Katrina Kamau, and I work with Food and Nutrition Service. Our agency is a small agency under the U.S. Department of Agriculture that's responsible for the nutrition assistance programs. So I wanted to thank you all for inviting us today to talk about some of the things that we've done to address food security during the pandemic. We could go to the next slide. Okay, just a little bit on our mission. Our mission is to increase food security and reduce hunger by providing children and low-income people access to food, a healthful diet, and nutrition education in a way that supports American agriculture and inspires public confidence. Over the last few months, our agency has worked with our state agency partners to identify regulatory flexibilities that will allow state agencies to continue to serve clients in a pandemic environment. When we're talking about SNAP, school lunch programs, some of the issues that children have experienced in schools, whether clients are able to get out to offices to actually apply. We've worked really hard over the last few months to find ways that provided a number of flexibilities to both the state agencies, our partners, and clients to continue to access benefits. Next slide, please. So in mid-March, FNS began to implement the provisions of the Coronavirus Act. The legislation authorized the Secretary of Agriculture to implement new programs, which also addressed increased benefits to clients, administrative flexibilities for state agencies, and then more flexibility, of course, in the application process. I'm going to talk about our FNS special nutrition programs first. That includes programs like the school lunch program, WIC, commodity distribution, child and adult daycare feeding programs, and then I'll talk about SNAP. So one of the recently implemented programs that you may be hearing about, and we're excited to hear that it was actually expanded for the school year 2021, but it began in March when school closures began. As a result of the Coronavirus Act, we implemented a new program called Pandemic EBT. Pandemic EBT is an optional plan. It allows states to provide benefits similar to SNAP EBT benefits to families with children eligible for free or reduced meals who were unable to attend school due to school closures as a result of the public health emergency. It was not a SNAP benefit, it's its own separate program, but SNAP EBT, which many of you may be familiar with, was the vehicle used to deliver the benefits to the eligible households. As I stated earlier, it has now been expanded into our current school year for 2021. So we recently issued guidance to states, actually yesterday, and going to be meeting with our regional state partners later on today to talk about the implementation for the upcoming year. So states have an option to provide those benefits again for children who are unable to attend school in person and receive their meal free or reduced. But not only did we implement Pandemic EBT, we continued with grab and go models where parents could go and pick up meals for their kids that were not participating. Is really similar to what we see in our summer feeding programs. We expanded that through the school year. So those programs still are operating where households can go and pick up meals if they're not attending school in person and unable to get those meals. We also have options in some of the rural areas where you have folks that kind of go out and deliver meals into the community. So you'll find a community organization that partners with the state agency and delivers meals into the more high-risk areas. For WIC, we've seen a lot of physical presence waivers, which basically allows the state agencies to continue to provide the benefit to the clients without having them being there on site and doing the nutritional assessment. And then also issuing those benefits remotely to households. Those are the types of waivers and processes that USDA continues to implement and allow state agencies and partners to participate in during the pandemic. Could we go to the next slide? For SNAP, SNAP is actually the division that I work in. So for households that are currently participating in SNAP, they also receive an emergency allotment. That allotment brings their benefit level up to the full benefit level for that household size. So many of you may know that SNAP eligibility is based on income and resources, and households' benefits could vary depending on the amount of income and expenses that they have in the household. Since March of this year, we have been providing an emergency allotment to every SNAP household that allows their benefit to be increased to the maximum allotment amount. So region-wide, that ranges in an additional amount of about $350 million monthly to each across Southwest region. So that's not national, that's just across Southwest region. We've extended certifications, which allow households to continue to participate in the program and not have their benefits cut off because they are unable to go into an office. We have also increased the number of face-to-face waivers where households can do their application process online and be authorized by phone. One of the real successes, I think, was the expedited online purchasing pilot. For a number of years, we were examining how households might be able to purchase, similar to you, me, anybody that purchases online, have things delivered. So how can we do that, make that same connection for SNAP clients purchasing with EBT, so that they're when they're unable to get to the store, but they can purchase online and have those items delivered to their home. Across Southwest region, 6 of our 7 states have implemented that option. It has increased access to about 5 million plus, where households are able to now purchase online from retailers participating in our online purchasing pilot and have their food delivered to their home. We're also seeing an increase in the number of retailers who are being brought on. We started with Amazon, Walmart. There were a few in some of the rural areas, ShopRite, that were participating under the pilot, but we're now expanding that to a number of retailers. There are some, of course, some issues that you have to deal with connectivity and secure encrypted purchases. So there is a process that retailers have to commit to and clear before they're approved for the pilot, but it has shown much success during this pandemic. Okay, I think that was the last slide that I have. I'd be happy to take questions from anyone that might have questions. But for more information about any of our programs, that's our public website. One of the benefits I think I've seen recently to the communication efforts that we've implemented was the online website. We have for each state, each waiver that they have been approved for under the pandemic, whether that's online purchasing, whether that's face-to-face waivers, all of that information is available on our public website. And so I thank you all for inviting us today to talk about some of the efforts that we've been involved in to increase food security. I know that food insecurity can greatly impact mental health. And so we're doing all that we can to assist families in recovering and maintaining food security during this pandemic public health emergency. So thank you.
Thank you, Katrina. And if anyone does have any questions, if you can submit them in the chat box. I'd also like to move on to an update from Mr. Brock Denzel on our Farmers to Families Food Box program, which is another program that has helped feed families, but has also helped our farmers. And so Brock is the Chief of Staff for the U.S. Department of Agriculture, Marketing, and Regulatory Programs Mission Area. This mission area facilitates the domestic and international marketing of U.S. agriculture products and ensures the health and care of animals and plants.
Yes,
Brock?
thank you. And it's a pleasure to be with you all today. Apologies in advance. I'm having some technical difficulties with my computer camera, so unfortunately, I won't be able to get that to work today. I am Brock Denzel. I am the Chief of Staff actually of the Agricultural Marketing Service, which is one of the two agencies in our Marketing and Regulatory Programs mission area. At AMS, we have 11 program areas, very, very broad agency. Our primary responsibility would be things such as we provide grading services for livestock, produce, shelled eggs. We do market news on all of those commodities. We provide oversight for the National Organic Program, the National Bioengineered Food Disclosure Labeling Program, among other fair trade and local and regional food market promotion programs. What you'll notice in that description is that typically we do not have that much to do on the nutrition front. We do have one program area, however, that does deal in that space, and that is our commodity procurement program. And typically commodity procurement for us, we partner with our FNS colleagues, and we provide sort of the logistical operations for some of our feeding programs, such as TFAB, as well as purchases for our tribal program, FDIPR. All of those types of things, we are the ones who actually go out and provide the contracts and procure and ensure delivery of the food to specific food banks around the country. And so if you think all the way back to where we were, it seems like a lifetime ago, but back in April and late March, we started to see a number of things happen around the country. I didn't know this going into to a pandemic, but it turns out there are two very separate and distinct supply chains for food that is typically goes towards a retail outlet such as your grocery store, and a supply chain that is focused more on food service. So your restaurants, your hotels, those types of things. And kind of as we realized the difficulties that were being caused by the pandemic and lockdowns and basically a collapse of the food service industry, we saw a number of things happen. We saw products such as milk being dumped. We saw fresh produce being tilled under and going to waste. And we saw sort of an overall inability to get products that had originally been destined for food service or would normally go through a food service supply chain to an end customer, actually getting through that supply chain in a meaningful way. So in response to that, and through the Families First Coronavirus Response Act, we found some legislation that allowed us to create a brand new program, which is the Farmers to Families Food Box Program. Initially, we set out for about $3 billion worth of these boxes sent across the country over the course of, in response to that, 4 months, and we are now up to about, or will be up to about $4.5 billion by the end of the calendar year here. This program, we've gone through a number of different iterations. I believe we're on phase 4 at this point. We started off really wanting to focus in on just getting these products off the market and into the hands of the folks who need them. Obviously, along with the food service shutdown and the collapse of that industry, there are many other effects. And one of the things we learned from our colleagues over at FNS is that lines at food banks were growing exponentially. And so we figured out we can procure this produce through a distributor who would normally provide that product to a restaurant or a hotel or something like that, and instead have them deliver that to a nonprofit organization, whether that's a food bank or a religious or a community organization, in order for them to provide sort of that last little bit of distribution and allow for sort of a new model to get food and not only food, but kind of staple products, your fresh fruits and vegetables, dairy products such as milk, cheese, other commodities, even some pre-cooked meat products as well to get some protein in there. So we created this program. Again, we've gone through a number of different iterations, but really what we were trying to do is get the food where it actually was needed and where it could be taken off the market and put to good use. This is sort of in line with what we do at AMS in terms of our market impacts and those types of things. Again, I said we are on a phase 4 at the moment. So we currently have partnered with nearly 50 distributors to deliver all across the country. A list can be found if you visit our website. It's ams.usda.gov. That website will have a link right to our Farmers and Families Food Box program, and you'll be able to see exactly which distributors we've partnered with and how much each one of their contracts are and how many boxes or how much food product will be going to specific states. So that's kind of an update as to where we are. The program, as I said, is set to expire at the end of the calendar year. So we've been sort of ramping this down a little bit, but there are still boxes out there and still boxes out being delivered. And it's, one of those things that I think was never intended to be a solution to sort of the long-term or systematic hunger needs in this country. It was very much designed to be a response program to very acute needs that we saw. But I think that really one of the successes that I'm taking away from this is that it really does and really has provided a little bit of a new model to show how fresh fruits and vegetables, as well as dairy and meat products, can really find their way into the hands of those who are food insecure, and really provide them, with better quality and access to better products than they might normally have had access to. So I'm going to leave it there. Again, thank you for allowing me to speak with you all and update you all on this program. It's my pleasure, and I'm happy to take any questions.
Thank you, Brock, for that update on the Farmers to Families Food Box program. I just want to show a few pictures. Horace Hodge and myself, along with our OPPE staff, have really helped our communities and organizations in our area with this program. And so these are just a few of the pictures of us delivering boxes. We actually went door to door. We've also helped with pop-up distribution events. And so these are just a few of the pictures that I just wanted to share with everyone. But this program has definitely helped a lot of families during this time. We'll now have a short break until 10:30. So we'll have about 12 minutes. If you're interested in listening to this session on recognizing symptoms of anxiety and depression in children and adolescents for suicide prevention, you can remain in this virtual room. If you're interested in the other session on adverse childhood experiences and trauma-informed support, you'll actually leave this room and join the second virtual room. That Zoom link is found on the event agenda that was emailed to everyone. Just click on Zoom link to join, and the next session will start at 10:30. So we have about 11 minutes until our next session begins. Thank you, everyone.
Hello, Bayou. Ash.
Yes.
All right. Bayou, I'm assuming that you're sharing the screen?
Yes.
Okay. Are you sharing it right now?
Yes. Can you guys see it?
I can only see what we saw last night. It's not the full.
No, it's a full screen, right? Where are you? Are you in a different room? You are in a different, you have to join to this room, to my room now.
I'm in your room.
Oh, you are. Yeah, you are. So are you going to? Yeah, you are in the right room.
I'm gonna put it on full screen right now. Let me know if you see it.
So who is going to? This is adverse childhood, right?
Yes. Is it in full screen for you guys?
Yeah, it is full screen.
Okay.
It's not on mine for whatever reason. I can only see the left half of the slide. so I don't know.
Is anybody else having that issue?
No, it is full screen. Something wrong in your computer, Mr. Hort.
Oh, we had this same situation last night and it was fixed, so it's not my computer.
Oh, I can see full screen.
But you're a technocrat, so I'm thinking about the other people that will be joining us.
Is anybody else having that issue, or is it full screen?
So we have 9 people here. Anybody else?
It's full screen for me. This is Barbara. Thank you.
Yeah.
Oh, okay. All right. Well, I'm not advancing the slides. I'm just doing introduction, so we good.
This is Sabrina. I can see it also.
So,
okay.
Mr. Hodge, is there any other breakout room in this? Or this is the only one?
This is the only one.
This is the only one, right?
Yes.
Because I see that there are 2 rooms. One is recognizing symptoms of anxiety. So they are doing it, right?
Yeah, they're doing that one. Yeah.
That was in the main room. Yeah.
Oh, so we are not breaking out. So only this is the one, right? Okay, good. All right, go ahead. I'm going to mute. So do you have a camera you like to switch on, or it's fine without camera also? It's okay.
The speaker's not in yet. I'm not sure. Mike. Yeah.
Okay.
I'm just sharing the slide.
Oh, so who
Good
is
morning.
the
This is Lieutenant Commander Tracy Murray. I am here, and hopefully you can see my video without issue.
Yes, I can see your video without the issue.
Thank you.
Everything is going live on. You're going live on YouTube also.
Well, all right then. That's a lovely surprise for today.
Yeah, there are a few people, like 20 people are watching on YouTube.
Great.
Not 20.
I don't see that my co-presenter has made it into this breakout session yet.
That's what I was just checking. But if that be the case, as moderator, we'll do what we did in the previous session, and we'll flip the script here and allow you to go first, Commander Murray.
Oh, it's okay. The way our presentation is set, it's really integrated. So it's one presentation where we're both sharing. So if for whatever reason he's unable to join, I think it should be fine.
Okay.
But hopefully we're able to troubleshoot or get him into the session before we begin.
Okay, we'll. After listening to the other sessions, we're certainly not going to stress about it. And by you, Ash, this will be recorded. Is that correct?
Yes.
So who is going to present? Who wants to be like, I have to make them co-host. So it's only Bayu, right?
No. Miss Tracy Murray.
Tracy Murray. Okay. She has a slide, or you're moving slide for her?
I'll be moving the slides.
Okay, then fine. Then she can just come and talk. She doesn't need to be co-host. So anybody else? Nobody else, right? That's it?
Her co-speaker, Mike Alkeems. We're still waiting on him.
Okay, okay. So that person is going to move the slide, or
No,
you're going?
I will.
Bayou would do it for both of them, so they don't need to be co-hosts.
Okay, good, good. So it's clear.
Yeah.
All right.
We'll get started here in just about a couple of minutes. So you'll just hold on for a couple of more minutes. Well, good morning, and my name is Horace Hodge, and I'm served as the USDA liaison at Prairie View A&M University with the Office of Partnership and Public Engagement. I want to welcome you to this breakout session where we'll be discussing adverse childhood experiences and trauma-informed support. Adverse childhood experiences, or ACE for the acronym. And we have two exciting presenters. For those of you that are just joining this roundtable discussion for the first time, We had a very, very informative general session, if you will, and I can only expect this breakout session to be more of the same, if not a turn for a notch up. So welcome to this breakout session. Our first presenter, and I'm not sure if he's on, I'm gonna go ahead and introduce him, but is none other than Mike McElmeans. I first met Mike. I've been to his facility in Houston, located in the 3rd Ward. I could just tell you without even reading this that he has a passion for early childhood education and intervention. And when I met him and saw what Generation 1 does, I remembered professor, or I guess you say teacher, was telling me that all that you ever needed to know, you learned in kindergarten. So we know that the early beginnings is very, very important, and particularly in the subject that we're dealing with today, and particularly in the times that we're currently in. But Mike is a Marine Corps Desert Storm veteran and founding director of Generation 1, which is a nonprofit that involves the collaboration of volunteers, churches, universities, and corporate partners to impact the lives of children and their families to improve the quality of life for the residents in Houston 3rd Ward. Generation 1's primary focus is early childhood education. In addition to his work with Generation 1, Mike founded CORE Alliance Disaster Relief, which has responded to Hurricane Katrina, Hurricane Ike, and the devastating earthquake in Haiti. Prior to this, Mike worked for Charles Schwab as a senior business development broker. In 2015, he was named the University of Houston Downtown Alumni of the Year. In 2009, Mike was honored with the Jefferson Award for Public Service. Mike is a devoted husband to his wife, Kinsey, and father to their 2 children, Jonathan, 18, and Kaylee, 7. Our second presenter is none other than the Tracy M. Murray, Dr. Tracy M. Murray. Lieutenant Commander Tracy Murray has been a registered nurse for 10 years with experience in clinical research, epidemiology, and nursing education. In 2017, Commander Murray became a commissioned nurse officer in the U.S. Public Health Service. She currently serves as a Region 6 Assistant Regional Administrator for SMAMSA in Dallas. Commander Murray recently completed a master's in public health with a global health emphasis at the University of North Texas Health Science Center. I would like to please welcome our 2 presenters. And Mike, if you're on, you're up first. And if not, Commander Murray, take it away.
Oh, thank you. Good morning. I do see Mike was able to join us. So we'll be presenting together. If you could go ahead and advance the slide, I'll be presenting on the first one. Thank you. So thank you all for joining us in today's breakout session. What we're talking about again is adverse childhood experiences, how they impact our children, and some resources available to you. Just to give you an understanding of ACEs, adverse childhood experiences, they typically fall into 3 different categories. We have abuse, neglect, and household dysfunction. Under abuse, that can be anything from physical, emotional, or sexual abuse. Neglect includes physical and emotional neglect. And types of household dysfunction can be mental illness, a mother who's been abused, divorce or parental separation. You have substance abuse or misuse in the family, as well as any relative being incarcerated, certainly a family member or a parent being incarcerated. And what we know from research is that ACEs can have like a dose response relationship, meaning that the more ACEs a child has experienced, the more likely they are to have some negative outcomes. So on this slide, you see there are about 10 different types of ACEs presented here. So the more a child has, again, the more likely they are to experience some negative outcomes, which I'll talk about on the next slide. Go ahead. But these impacts, these negative impacts, they are not definite. So just because a child has experienced 1 or more ACEs does not guarantee they will have these negative impacts, but they certainly are more at risk. And those impacts fall into behavioral as well as physical and mental health. Some of the behavioral outcomes can be smoking, alcoholism, drug use. And in physical and mental health, we see children who have experienced a certain amount of ACEs are at higher risk for health conditions like diabetes, STDs due to more risky behavior, stroke, COPD. Again, that can be related to increased smoking habits, as well as depression and suicide attempts. And so what I'd like to do now is actually turn it over to Mike to share some of his own experiences and kind of lay some foundation for what this might look like.
Thank you. So yeah, we work in the inner city, so we see this up close and personal. We've had a handful of kids live with us that needed a safe space, so we've seen it there, and we've adopted a kid from the third board who's been with us for over 11 years now. So I was just going to give you some examples of what happens and what it looks like in a personal level when children experience these ACEs. And just a side note, grief is the #1 indicator of high school dropout. That's over physical or sexual abuse. Grief, as mentioned earlier, can be a result of a parent going to prison, death, or divorce. Most kids that grow up with majority of these ACEs could live 20 years less than somebody growing up without these ACEs, just due to the stress and the different health issues that follow that. One of the things we saw with some of the kids that lived with us was because they didn't grow up in a safe environment, their mind never developed the natural ability to tell when you're safe. And to compensate for that, they would ask a million questions. Where are we going? How are we getting there? Who's going to be there? What are we going to eat? When are we going to eat? And 50 more questions. And if everything happened in that order as we explained it, their brain told them they were safe. But if all of a sudden you stopped to get gas and that wasn't on the list, you wrecked it, you had to start over again. So our son used to wear us out for years like that, but that actually got better, and he's been in a safe, loving environment long enough that that part of has gotten better. Associated attachment disorder can come out of these ACEs and come out of a stressful young age. And what that is a child 1 minute is breathing on your neck and just has to be right here, and then 5 minutes later they're 20 feet away and can't get any closer. And that's another part of ACEs and sensory deprivation. Defiant disorders are pretty prevalent when you have a lot of ACEs, and a defense mechanism comes up where you argue about anything and everything, because if you're talking, you're probably not getting physically abused. So the kids try to keep talking, and when it's extreme, like it was for us, in one case, the child argued themselves out of a piece of cake by arguing if it was chocolate or a different kind of cake, just because that defense mechanism is so prevalent that they argued out of a cake, they argued out of candy. It's just, if I'm talking and we're arguing and we're even yelling, I'm not getting hit. That's the comments I had on that section.
Awesome. Thank you for sharing, Mike. Could you advance to the next slide, please? What I wanted to do here was transition into give some additional examples that you might see as signs of trauma in preschoolers or in early childhood education programs. And so, as Mike mentioned, you have additional examples of separation anxiety or clinginess. One thought could also be regression in a previously mastered stage. So where you might see a child who is talking, potty trained, and toileting with no issues, that they revert back to inability to really express themselves in words. Or you might see that they are wetting the bed more often. than previously expected, or even just lack of developmental progress. So whereas their peers are at a certain level of reading or understanding comprehension, they're just not getting there. Or recreating the traumatic event or playing it out, talking about it over and over again. Difficulty even going to sleep, not wanting to go to sleep. And then also somatic complaints. So they just have aches and pains and overreacting if they had a scraped knee or something in that area. And again, I wanted to turn it over. Mike, did you have any additional comments here?
Yeah, I've just seen all of this happen. You know, a lot of pre-K children are suffering from sensory deprivation, and if the teachers are not trained properly, they see it as a behavioral issue. And if you address a sensory deprivation issue with a behavior, you know, with punishment, you exasperate the child, you stress the child out more, and actually create more trauma. You know, we've all heard the saying, didn't your parents love you enough and hug you enough when you were a child? And the answer is no, they didn't. And what we've seen is two things a child absolutely has to have is one, they have to feel safe, and they have to have at least one adult loving and supportive. And if they have those two things, they can overcome quite a bit. But if they don't have those, and they're always constantly in stress, that cortisol and the adrenaline is flowing. And if that toxic mixture flows too much, your brain can actually get rewired to either fight or flight. And we've seen so many kids, they're either going to fight every second or run from it every second until you have, you know, and it takes a good long time and a lot of training and education and coping skills to reverse that, or at least be able to work around it. So the longer the kids are suffering from these ACEs and they're not treated properly, could actually create permanent damage.
Absolutely. Thank you. Thank you for sharing on that. Can we go to the next slide, please? Thank you. Some additional examples of signs of trauma in preschoolers, in addition to what Mike shared, are again, changes in behavior. So angry outbursts in a generally calm and quiet child, over or underreacting to any type of bright lights or sudden movements. Again, that could be very scary or anxiety producing. Worrying about whether the traumatic event will reoccur. And then even having new fears. So child that didn't worry about monsters under the bed, now they're suddenly afraid of what could be in the dark or behind a door. Go ahead to the next slide, please. But certainly ACEs can be prevented. There are things we can do to support our children, our pre-K students, and any child in dealing with those ACEs. And some examples can be strengthening economic supports for families. And that's certainly a difficult thing, a necessary thing in the current pandemic, with many people losing their jobs, losing the financial stability of their home. And as an employer, how can you create family-friendly work policies? Again, certainly with what's going on with the pandemic and schools being closed, or constant changes in family dynamics. Changing social norms to support parents and to encourage positive parenting. So how do we begin to help parents parent better, right? And the last one here on this slide is providing quality care and education. So how do we provide funding and supportive environments for preschool and early childhood education programs so that it's a safe place for children to learn and develop? Go ahead. Some other examples are, again, are around enhancing parenting skills. So there are certain programs about home visitation. So to bring support into the home, to support the family, the parents in caring for those children, right? And building, again, parenting skill and family relationship approaches. So as a family, how do we work together to raise healthy and happy children? And then intervening to lessen any harms. And this might involve some additional care, therapy, and working with professionals to support the children and the family. Go ahead. Regarding trauma-informed support, so these are some additional ways that we as a community, care providers, caregivers can support children who have experienced ACEs. And one of the main things we can do is maintain a usual routine. As Mike mentioned, some normalcy, something they can expect, right? And to help them feel safe. Also giving children choices. Oftentimes in those traumatic experiences, their control is lost. So if there are opportunities that you can give a child to choose, even if it's are you going to take a nap on the couch or over here in the bed? Are you going to color with this color or that color? Those choices allow them to regain that sense of control. Also thinking about setting limits when there is inappropriate behavior. Again, not punitive, but having some type of limits so that child can stay within and understand. Mike, did you have some additional comments here?
Yeah, we just kind of experienced this firsthand. The maintain usual routines is it's very important, and that does create the safe environment because it creates control. And when you suffer from ACEs, you're out of control and you have trauma coming at any minute, and there is no structure. We've noticed the kids will fight tooth and nail as you're applying the structure, but once they've accepted it, they have a level of peace and can function pretty well in there. Now they very often want to drift out as quickly as possible, but they, as hard as they fight to not have it, is how much peace they do have when they're in it. And given the children choices, we, our son's 18 now, and he's got some pretty big things to process as far as forgiveness and for some of the trauma that he suffered. And talking to his counselor and talking to some other people, they told us he needs grace and love by 1,000. You can't correct him on everything, and you need to let him make choices and decisions on his own so he feels like he has control of his life again and can create some safety to get him to a place where he then can start processing. And when we went through that, it was tough because it's very counterintuitive to how you would want to normally parent. And he missed 30 classes in school, was late to 21, had 2 Fs and 2 Ds as we were watching him make his own choices. But the counselor warned us, it may look ugly for a while, but he'll get it, and he actually, we saw him go, but then he got it and came back up, started passing his grades. But the most important thing that was more important than the grades in school was the processing of his heart and being healed from these traumas, which he has been able to make huge strides. And we weren't making those strides when we were trying to keep him structured and keep him disciplined and trying to, not understanding for myself the effects of ACEs and what trauma does. I'm trying to raise him like I was raised, and that does not work. So you got to kind of let all that go, trust the Lord a lot, and let him feel in control, feel in peace, and then get to that place where he can process. So we actually watched that work out. We're still working through it, but it was hard to do, but it was very much worth it.
Absolutely. Thank you. Thank you for sharing that. The next slide, please. Some additional examples of a trauma-informed support approach for children is to give simple and realistic answers, to clarify things that they don't understand, right? And if it's not a good time to talk, give a time and a place when they can talk, creating that safe space for children, and being sensitive to cues in the environment. So understanding what's a signal for that child that might trigger some anxiety and fear. Is it certain loud noises? Is it being in the dark? Is it the uncertainty? So being sensitive to that and helping the child anticipate it, right? That goes back to, as Mike shared, to explain what's going to happen so the child can anticipate it, right? And then being aware of how other children react to the child and being supportive for them, but also protecting that child from children who may not understand their experiences. Go ahead. One more slide. So what I'd like to share with you now are some of the resources that we have available through SAMHSA, the agency that I work for, Substance Abuse and Mental Health Services Administration. And one of the key tools that we have is the Child Trauma Toolkit for Educators. This is available for free for download on our site through the National Child Traumatic Stress Network. This toolkit really breaks down lots of resources for educators at different levels on how to recognize and support children who experience different types of trauma in their life. Go ahead. We also have our Center of Excellence for Infant and Early Child Mental Health Consultation. And so what this is pairing family members and adults, anyone who works with or cares for infants and young children in various settings. So it doesn't have to be just in school, but in different settings where you can pair with a mental health consultant to really look for preventive strategies to support the children that you love and care for. Go ahead. Back to the National Child Traumatic Stress Network. So one thing we know is about 1 in 4 children will experience a traumatic event by the age of 16. 1 in 4. So it's very likely that a child in your life has or will experience some type of adverse childhood experience, an ACE, a trauma. And the National Child Traumatic Stress Network provides several tools to support you in supporting that child. Go ahead. Here's some kind of breakdown of those resources. So you can go to the website there for the National Child Traumatic Stress Network and find resources for any particular audience. So whether you work in child welfare, maybe it's for a family, you are the family, or maybe you're getting tools for a family. Perhaps you're a healthcare provider, or maybe you're in the criminal justice system. There are resources specific to your specialty. And also for different types of traumas. So early childhood, that would be in the space of ACEs, disasters, abuse, all of those things are available to you. And they even have training, so webinars that you can look at and participate in. There are bilingual resources, so available in Spanish, and then some of the key public awareness campaigns that they are advocating for. Go ahead. Here's just a list of some additional technical assistance centers through our agency, SAMHSA, that may be of interest to you. Again, we have a National Center on Substance Abuse and Child Welfare. The Geiss Center really focuses on a criminal justice lens of supporting behavioral health, and also things like our Suicide Prevention Resource Center and tribal technical assistance as well. Go ahead. So I just wanted to share a final thought with you in closing. And as I look out my window here, so my neighborhood is filled with these huge pecan trees. They're gorgeous, very gorgeous. And they have these golden leaves that are falling. It's a really beautiful transition into the fall season. I love like walking around my yard, picking the pecans and seeing these squirrels have a whole field day running around hiding their pecans for winter. Now, my neighbor across the street just planted new pecan trees in his yard after a storm destroyed all his other trees. And so every day I see him and he waters his trees. He pulls the water hose all around the yard. There are stakes around each and every tree to support it when the wind is like a little too strong on certain days. And there's mulch around the trees to keep the soil moist and fertilized. And then occasionally he has to call out the pros to carefully shape the wild growth these trees are like sprouting out. So I don't know about you, but that seems like a whole lot of work for a little old pecan tree. But that's what you do when you care about its growth and development. So if we want our children to have resilience to withstand the strong winds that will most certainly come, we must be those supporting stakes, firmly planted and wrapped around them. If we want our kids to have deep roots to keep them securely grounded in a storm so they're not destroyed, we have to water them faithfully with love and care. So I challenge each of you to look around and find children in your own life who you can support. You don't have to be all things to all children, but you can make a difference in some way, no matter how small. Everyone has the power to do something, even if it's just creating a safe space for a child to talk about their experiences. Our children's future depends on us working together on their behalf. So my hope is that this presentation gave you the knowledge and resources you need to do just that. And so I'll turn it over to Mike if you have any additional closing remarks.
Yeah, just, you know, the education and of the child, of the social emotional learning and how to get around the ACEs, and to the parents, how to prevent the ACEs in the home. And we found that the child is one of the best teachers for the parent. We had a 3-year-old go home one day and tell her mom she wasn't using kind words to her. And it sounds like a very simple thing, but the mom didn't understand what kind words were. So she actually came into the school the next day and said, "What is my child talking about kind words?" So we were able to sit down and explain that to her and talk. And we found when the kids get it at school and they get to understand it, they have their safe place. They are taught when they realize they're triggered or they're going to an emotional place, they will excuse themselves and go to the safe place and regulate themselves and come back. They'll take that home and they'll sometimes designate their own safe place and walk out of a situation. And the mom's like, "What are you doing? What is this?" "Well, I'm in my safe place and I'm going to regulate." And then the mom comes back the next day and wants an explanation of that. So the teaching the kids at a young age really helps the parents see it, and then working with them. And we try to get our parents just to really work on a couple of things: love and support, making the home feel safe, and then the structure around sleep, food, rules, and homework. We have a lot of 3-year-olds, elementary school kids that go to bed at 3 a.m., live off chips and candy. We had a young man come live with us for a while. His mom sent him with a case of Dr. Pepper and 18 extra large Snickers. That was his food. And we just saw the carb crash over and over. It took 2 weeks of feeding protein and feeding on regular schedule to get him off that continuous carb crash. And then encourage with the homework. So it's you can do a lot of preventative. You can, I think it's up to 6 or 7 years old. You can still do therapy and you can still change outcomes. You kind of get past that and it's starting to get into coping mechanisms and different things. So if we get the children early enough, work with their teachers, work with their families, can make a huge, huge difference in their future.
Okay, great. Thank you. And that concludes our presentation. I'll turn it back over to you, Mr. Hodge, and the technical team for any direction on how we can rejoin the main group. You're on mute, Mr. Hodge.
I'm sorry. We do have a few minutes that we might can take some questions. But before we do that, I just want to tell you, I could listen to you all for another hour, if you can believe that or not, because you're so calming and your passion and your therapeutic nature, if you will, really comes through in your presentation. I would give you an opportunity. First of all, let me see if there are any questions from anyone. If you do, put them in the chat box, and we'll try to get to those before we go for break, because we go to break at actually 11:15. But so what I would also ask you to do, Mike, and this is the infomercial time for you, and also for you, Commander Murray. What is trending right now with Generation 1 or with your organization, Commander Murray? So what are the hot spots right now that you're doing? And maybe even talk, Mike, a little bit about how people could assist your organizations or anything. I'll give you just a few more minutes to in that space.
Yeah. So what we're doing, what we were doing prior to COVID, but like we've talked about, COVID just exasperates everything. Our kids are desperate to be at Generation 1 because it's their safe space and that's where they feel their love and it's where their community is. But what we're working hard with right now is with a couple of different universities and a hospital to develop and create evidence-based outcomes. So we're not creating anything that's brand new. We're taking social emotional learning and mixing in trauma and grief therapies and family, a ton of family therapy and family counseling, and trying to blend together what the best curriculum or program could be for early childhood education that's evidence-based. So we're collecting data, we're doing a lot of surveys and communicating a ton with our parents, because in some months or even within a few years, we want to have an evidence-based program that is proven to address ACEs and create resilient children that can overcome those things and go on to be very successful.
Well, thank you very, very, very much. And I before you speak, Commander Murray, I want to say, talk a little bit about the relationship that Prairie View has with your organization. And I'm going to call on Dr. Williams in just a minute, Dr. Williams, to augment that. But Commander Murray, what's going on down in your space right now?
Certainly, thank you. So my agency in my role, ACEs and childhood education, is a small part of what we do. We actually have been serving in Louisiana in support of Hurricane Laura disaster recovery and supporting behavioral health efforts there. So we do quite a bit of work in sharing information from everything, including partnerships with DEA to increase the number of providers who are prescribing medication-assisted treatment for substance abuse issues, to connecting our state and regional partners with funding opportunities from our federal agency. And then also one of the things that I'm very passionate about is diversity in behavioral health, in the behavioral health workforce. So seeing more people who look like me that I can go to and speak to about my issues and how that relates to stigma surrounding behavioral health and mental health issues, certainly in minority communities. And so my agency currently has funding and resources to support HBCUs with behavioral health ambassadors, as well as some postgraduate level diversity programs. But I would love to see ways that we can begin that pipeline very early in childhood education from grade school on up, to begin to encourage children to talk about mental health and wellness issues and see value in dealing with those issues, and how that can begin to break the stigma and break the chain of unhealthy relationships and behaviors in our families, which then in turn affects our communities as well as our nation.
Well, thank you very, very much. My middle daughter is a counselor, and I could tell you some stories in the parent-child relationship that she talks to me about, and it's certainly an art to work in that space. And I just want to appreciate you and Mike for all that you do, and more importantly, the conviction that you have for doing what you do. And at this time, I know from the beginning, when we started doing these summits, virtual summits, and OPPE were hosting them, mental health was one of the topics that due to us having to go virtual versus in person, we did not have that on the first agenda. But my supporter here locally, and I'll say locally here at Prairie View A&M University, Dr. Carolyn Williams, would constantly remind us that we didn't get to that space, but we needed to do it. And here we are today. And I would like to give her a minute or so just to talk about, extension and the relationship into families, and give her perspective on that. Dr. Williams, would you please?
Well, thank you, Horace, and thank you, Mike, and Dr. Murray. Your presentation was truly, truly powerful. And as I mentioned earlier, we are the hope, and I could see all the hope in you all as you presented this information with the resources and what you have done in the lives of children. our outreach program, touches the whole family. And so we have lots of opportunities to share resources and to provide families with information to help them. And so learning all about this, and I know Sabrina is on here, she is training our extension agents now with some mental health curriculum so that they can kind of identify the symptoms and help families and know how to recommend or refer families to get assistance. So I would like to talk back with Dr. Murray to see how we could partner together, especially since we are at an HBCU, since y'all have funding. We like money and we do well with it once we get it. We don't just frivol it away. We are intentional in our efforts to make a difference. And so I look forward to visiting with you. We're already doing some stuff with Mike at his facility with the families and the youth. And like I said earlier, it takes all of us. We need each other, and the families need us more now than ever. And I'm glad that we are open to sharing what they need. Yeah.
Well, thank you, Dr. Williams. I appreciate that. And yes, you're right. I did see Sabrina on, and she's been engaging. I've been reading her chat box messages, quite encouraging. And so we thank you for that. And we thankful for the partnership and the outreach that the Cooperative Extension Program at Prairie View does. And certainly the connections that we made with Generation One in the healthy eating, because as we said before, if you're hungry, you ain't too much worried about much else. It's hard to mitigate those ACEs experiences. So thank you very much. And we'll get back. The instructions would be that you would go back to the Zoom link that for the first session. That will get you back into the general session and for the closeout session on that. So thank everyone for being here. I know this is very much needed in the times that we're in. So again, thank you, and hopefully you've been informed or enlightened on some ways and some resources that you may take back to your communities or to your organization that will have better outreach in dealing with this mental health illness or mental health wellness, if you will. Thank you all so much, and we'll see you back in the other room. Unless there's any further question. If not,
we have a session 11:15 here. Substance abuse, mental health.
Yeah, yes.
So that is here at 11:15.
Okay, it's still in the same room. Okay, there's another one. Okay, very good.
Other room has nothing till noon.
Right.
Because that session.
Thank you. Thank you, Ash. And we'll come back in here shortly then. Thank you so much. Appreciate that.
Minutes this session, because the other session has nothing right now. So the other session will start at 12. So.
Okay. Okay.
If I see the agenda. So.
Correct. You are correct, because the other one closed out. Okay. Very good. So we'll about a minute and we'll start the other section. Thank you.
I'll just put the agenda.
Okay.
Hi, Horace. I'm Dr. Collier.
Yes, I see you, and I'll be bringing you up in shortly.
Oh, okay. Can I get control so I can bring up my slides?
Yes. So you are doing substance abuse, right?
I am. Yes.
Very good. So let me meet you.
You are in the right place.
And thank you, Ash, for catching that on the second session.
I'm confused that what is going on here. If everybody goes from here, there is nothing going on in the other session.
Gotcha. Great.
Both sessions. Okay, so Crystal, you got it.
Yes.
Okay, so you can share your screen if you want now to test it, because I see the agenda there, so I can stop sharing and you can go ahead and do it.
Great.
Yeah.
Okay. Well, we'll go ahead and get started just for time's sakes here in about another couple of minutes. Well, good morning. Again, my name is Horace Hodge. I serve as the USD liaison at Prairie View A&M University with the Office of Partnership and Public Engagement. And I'd like to welcome you to the second breakout session entitled Substance Abuse and Mental Health. And I know the other session, we'll probably have some more people joining us, but we're going to go ahead and get started. I would just say if you have any questions, put them in the chat box and we'll try to get around to answering those if time permits. So without further ado, I would like to introduce our presenter for this breakout session. Dr. Crystal Collier has been working with adolescents and adults suffering from mental illness, behavior disorder, and substance abuse since 1991. She created a comprehensive prevention model to teach the neurodevelopmental effects of risky behaviors to children, teens, and parents, which was selected for the 2015 Prevention and Education Commendation from the National Council on Alcoholism and Drug Dependency. In 2018, she was awarded the Torch Barrier of the Year Award by the Texas Association of Addiction Professionals for her prevention work. In 2019, the Houston Counseling Association named her Counselor of the Year. In 2020, Dr. Collier published her long-awaited neurodevelopmental parent guide entitled The Neuro Whereabouts Guide to Helping Families Who Want to Prevent Youth High-Risk Behavior. So without further ado, let's please welcome Dr. Crystal Collier. Dr. Collier.
Thank you, Horace. I really appreciate that introduction. I know it was a bit wordy, so thank you very much for getting through that. So I am a therapist, a researcher, and an educator, and I study high-risk behavior for a living, and it was really born out of my own experience being a kiddo who engaged in high-risk behavior. These are pictures of me as I was growing up. I was about 5 years old. Whenever I think of my inner child, I think of this picture right here with my little blonde curls. Before life was hard and it was innocent. My parents were married and we stopped on the side of the road when the spring flowers were blooming, as families do. And a few years later, my parents got a divorce. This picture was taken when I was about 11, 12 years old. And that's when my parental supervision was cut in half. And I had a lot of anxiety and discomfort in my own skin. Went to a brand new school and I thought I'd take summer school classes to get to know kids. And of course, that's not the best idea because the kids who have to take summer school make some bad decisions. And so by the time I was 16 years old, I had an intravenous drug issue and had been shooting up dope for quite a few years at that point. And then was always a really smart kid, graduated a year early from high school because I took a lot of summer school classes. And then I had an overdose when I was 18. So this big Texas hair picture of me at the end was taken when I graduated from rehab. I have on a t-shirt that says drug-free body, and I was so grateful to be alive and sober because I had a really scary overdose that I almost didn't survive from. When I got into recovery, which is February 3rd of 1989, I started to question, why did I make such terrible decisions? I was a good kid. I'm a smart kid. What the heck is wrong with me? I had so much shame. So I started researching this and I found so much information about the brain and how it grows and develops and how high risk behavior like drugs and alcohol, depression, anxiety, withdrawal, isolation, how those affect the brain. So that's what my book is about. And I put it into the chat room. If you're interested in taking a look at what it is, I wrote it in infographic style, so it would be appealing to our readers of today. But what I want to talk to you guys about is this intersection between substance use and mental health. It's always important if you are a clinician or somebody working with clients to assess what came first, the mental health or the substance use. Is the mental health came first, the substance use most likely is a self-medication. If the substance use came first, it's more likely that it's genetic or familial in orientation. So let's take a look at some of the numbers. It's important to remember that substance use disorders, I'm going to call those SUDs, go hand in hand with co-occurring mental illness. And here are the top 5: antisocial, depressive disorders, phobias, anxiety issues, generalized anxiety, GAD, and trauma. And the more co-occurring issues a client has, the poorer their treatment outcome will be, which makes sense because we have a lot more things going on and the prognosis is poorer when there are less skills and more mental health problems. So about 43% of adults with a SUD, a substance use disorder, have a co-occurring mental illness. Now, about 60% of those are women and 30% are men. And 60% of the women who are in that category and 30% of the men in that category have a history of physical trauma. And what we see is that about 47% of the women and 17% of those men report a history of sexual trauma. So this is where trauma and PTSD overlap. What we also know is that about 60% to 70% of women enrolled in substance use treatment report a history of partner violence, compared with about 25% of women in the general population. Something's going on. Women are more likely to experience sexual trauma, but men are more likely to experience physical trauma, but we're seeing more and more men reporting sexual trauma as the years go by. Now, I know you guys have talked about this today, that adverse childhood experiences research really shows high co-occurrence levels with substance use disorders and childhood experiences, the traumas and wounds that occur when we're young. And so I'm going to talk a little bit about what those are. This is a short list of some of the traumas and wounds that, when experienced as a kid, changes brain trajectory, literally. And we learn cognitive, affective, and behavioral ways of coping with these that may not translate into healthy, functional life as an adult. Child maltreatment is associated with severe alcohol dependence, earlier onset of use, earlier age of dependence, multiple substance use, and more frequent substance use. Kids who are maltreated as a child, either physically abused, neglected, they have a greater risk of high school dropout. Now, it's quite interesting because I work with kids primarily, and of course, adults in recovery and families. But what I see is that when they're young, they'll say things like, I don't want to be like my parent, my dad is an alcoholic, or I can't do what my mom did. But once they move into adolescence and they're starting to individuate, what we see is they end up being very vulnerable to substance use, even though they were staunch advocates against it when they were little. So let's talk a little bit about why this is. It has a whole lot to do with family of origin issues. So I call these FOO wounds or FOO buttons. And these are core wounds that fuel addiction. All we want to do is escape the pain from these wounds, and self-medication through drugs and alcohol and other high-risk behavior like technology addiction, self-injury, eating disorders, gambling, all of those can be ways that we escape this pain. So I don't know if you guys have seen this poster or not, but you can find it on Google. This is a poster that depicts the rigid family roles that can emerge in an alcoholic or a drug addicted system. And so if we have a parent, which is depicted here in the middle, that may be chemically dependent, what we see is that the family members surrounding that person may move into very rigid type of roles, such as the chief enabler, who enables the behavior, the family hero, most often the oldest child in the family, who takes care of everything and makes sure that they perform to take the focus off of the negativity. There could be a mascot. This is the kid whose role is to be the cute, funny one. Or there could be a scapegoat. This is the kid who gets in trouble all the time, and the alcoholic or the drug addicted family member blames this one for the problems in the family rather than taking a look at what's going on themselves. And one of the saddest roles, I think, is our lost child, who her job in the family or his job in the family is to be the one no one has to worry about. And so they don't get a lot of needs met, and they gravitate away from connections with people because they're so painful. What is important to remember is that in a healthy family system, we play these roles, but they don't become rigid. It's very common to see kids acting out and then moving back into healthy roles, being silly, trying on different identities, getting lost in video games for a while. But in a dysfunctional, unhealthy family system, these roles become rigid and fixed. We take these ways of thinking, feeling, and acting with us into our adult world, which does not help to create a healthy family of choice. And so sometimes what we also see in unhealthy family systems is unhealthy family rules. Don't talk, don't deal, don't trust, don't feel. A lot of times when I'm working with a kiddo who grew up in an alcoholic or a substance using system, we almost have to deprogram them. And because we hear, they've heard parents say, don't talk about what happens in our family. I can't believe you did that. Do you see how you caused mom to drink? All of these different blame and denial and not talking and unreliability and control that you see in unhealthy family systems have to be unlearned. And sometimes this can be very validating for people who struggle in these systems, but other times we hold on to those rules quite rigidly, unfortunately. But what we see in addicted family systems is a lot of negative effects, ways of coping that little kids figure out how to do that keep them alive in that addicted family system. but can result in mental health problems like dissociation, dysregulation, behavioral problems. They may have difficulty in healthy relationships, setting boundaries, not knowing how to do that. They may have intimacy issues. They don't learn really good communication and have problems with trust, and a lot of times don't bounce back as quickly, and then may escape in some sort of a high risk behavior. And one of the most important things that I've been studying for my career is the effect of arrested development. And so when I think about that, I think about my early days when I started studying how the brain is affected by addiction. And I really started with this period in time, age 11 all the way to 25, which is the second phase of brain development. So let me kind of reverse my thought process here. The first phase of brain development is birth to age 11, 12, when we grow about 200 billion neurons. Then when we go through adolescence and young adulthood, we prune away a lot of those neurons and create this well-sculptured brain that has 100 billion neurons left. So here's what's going on. We need room to create more myelin and more dendrites. This is a neuron magnified by quite a bit. And what we see is this long axon is covered with myelin. Myelin starts to thicken at about age 11, 12 and keeps thickening until we're about 24, 25, and then it starts to taper off. The thicker this fatty tissue is that covers your axons, the faster thinker you will be. And we call that processing speed. Then you can see these dendrites that reach out from the end of cells. I love dendrites because dendrites are literally the hardware of learning in your brain. Every time you learn something new, you grow another dendrite that reaches out to another cell. Let me show you what that looks like. This is a neuron, and you see these long dendrites that are reaching out like branches and roots of a tree. This is actually a magnified picture of an infant's neuron. And as these neurons start to grow and develop, all the way up until age 2, you can see the thickening of the myelin and the branching out of the dendrites, creating long strings of neurons in our brain for the skills we're engaging in. And this is what it looks like from the outside. As a child's brain grows and develops, a lot of this thickening happens within the prefrontal cortex or the frontal lobe. And you can see the darker the color, the less gray matter. Gray matter is actually those neurons. We prune away the ones we're not using to make room for myelin and dendrites. This is a critical time in brain development. But unfortunately, the second phase is when we engage in a lot of risky behavior. And if we've already experienced child maltreatment earlier on, our chances of engaging in that are greater, or also suffering from mental health problems. What I found most interesting is that 50% of anxiety disorders are diagnosed prior to the age of 6. And the average age for onset of depressive disorders is between 11 and 15. And so these things start to come on soon. And it's important to remember the use it or lose it principle. If our children are not using the prefrontal cortex and growing long strings of neurons for executive functioning skills, what happens is they start growing neuronal chains for the other types of coping mechanisms. So our frontal lobe's job is to be the CEO of our entire body. So what we see is that in the first phase of brain development, we grow these lower level executive functioning skills all the way up through elementary and middle school. These are the ones that we need to kind of wake us up in the morning, getting oriented, remember our lunch. And it's the first layer of skill scaffolding in the brain. When we hit age 11, 12 in phase 2, we start growing higher level executive functioning skills through middle school and high school and for the rest of our lives, peaking in college, around college age, around 25. Now, these are the executive functioning skills that we need to grow up and get out of our parents' house and fully functioning as a relational adult. Impulse control, problem solving, decision making, judgment, emotion regulation, frustration tolerance, and the ability to feel empathy. These skills grow during that second phase of brain development. But what if you're using drugs or alcohol or suffering from chronic mental health, like childhood maltreatment or trauma? Let's answer this question. And it looks like this. This is a functional MRI looking from the top down into the brain. And what we see is that in a healthy brain that is sober and not suffering from mental health issues, all of the parts of the brain are on. There's electrical activity and blood flowing everywhere, which means the brain is working together for optimal functioning. The top slides are taken 1 second apart of a person who's been using drugs or alcohol. But what is very interesting is if you look at brain slides of somebody who's afraid or in trauma or shock, you see the exact same thing. The limbic system is lit up either because of fear or drugs or alcohol. The same part of the brain that processes dopamine from drugs and alcohol is the same part of the brain that processes emotions. That's what your limbic system does, those two things. And what you see is the frontal lobe is off in the person who's been using substances. Same thing if they're in chronic fear or stress. It can really shut off the prefrontal cortex as we go into fight or flight mode. The scary thing to me as I was realizing and looking at all these brain scans is what if you're between the ages of 11 and 25 and you're growing your frontal lobe, those higher level skills? Do they get to grow? Well, you guys know the answer to that. It's no. And we call it arrested development, which unfortunately means you may not grow up with those executive functioning skills and repeat the same errors that you saw your parents make. So if you start using here at about age 12 and you don't stop using consistently until 20, your frontal lobe won't look like this one. It may look more like this one or more like this one. You guys, by the grace of God, I feel so lucky that I was able to get sober at age 18. I had 7 years of frontal lobe development. Hopefully I was able to catch up. But what if I had not? If I had continued using up until the age of 25, I would suffer from arrested development and be functioning executive function wise at an age 12, 13, 14, 15, 16 when I started using really heavy drugs. And so what we see is the perpetuation of mental health and substance use problems in kids who were maltreated and went through adverse events. Now, it's critical to remember that it takes time to heal. And this is a beautiful study that illustrates that. This middle line is a brain of somebody who is addicted to cocaine who's 10 days sober. And the same person 100 days sober on the bottom. You can see the frontal lobe is starting to turn back on. But what we know is it takes about 18 months for your average drug or alcohol addict to move back to normal level of frontal lobe functioning. That is a long period of time. It's very important to remember not to do trauma work during that time when somebody's newly sober, because we don't want to turn their limbic system on because of fear. We want to wait till they're stabilized before we do that kind of work. But we also want to make sure we treat mental health issues as soon as possible. A lot of times, if you send clients to a clinician who doesn't have addiction experience, they might treat the mental health problem, but neglect the substance use. But the opposite is also true. Many mental health specialists forget to even ask about substance use. And it's important that you guys know that up until 3 years ago, it was an elective in school addiction class. The KCRIP accreditation organization finally decided, no, we need to make sure that this is a required class. So there are hundreds of thousands of clinicians out there who've never really had the education on this. And if you ask your average MD, how much addiction medicine do you get in school? They'll tell you 15 minutes maybe. They learn how to chase symptoms rather than understand the origins of addiction and how to treat it. This is why the American Medical Association created an addiction specialist. You can become an addictionologist by going back and getting a separate certification. So they also have a website of addictionologists all over the nation so that you can choose a psychiatrist who has that certification. Now, here's the scary part. When your frontal lobe is off for an extended period of time, whether you're a kid or you're an adult, Remember, your frontal lobe is the part of the brain that connects to other people, makes good decisions, regulates. When it is addicted, what we see is something that has been coined acquired narcissism. And I want you to think about somebody that you know who might suffer from addiction or chronic mental health issues that potentially arrest the frontal lobe. They have difficulty attuning to those around them. They have difficulty self-reflecting and accurately appraising their behavior. They have little capacity for that, but they project and they say, well, you're the fault. See what you made me do. They project blame onto others. Very poor impulse control. They focus on themselves and their addiction, and they start creating a life that surrounds those issues. And then, of course, vacillate between emotional extremes and stay in a lot of denial. I actually did some work with a client this week who has an addiction, and she started engaging in behaviors like cheating on her marriage and was just amazed at why she was doing these things, because they're really not who she is. But in her addiction, her frontal lobe is off and she's not making decisions that are good for her and her family. Important to remember that when we're treating somebody who has co-occurring issues, especially PTSD and substance use, they have very high levels of mistrust toward us as treatment providers. We have to train our clinicians to know this, and we can work on regulation and co-regulation and attachment with our clients. This is why treatment takes a long time when we're working with co-occurring issues and people who had trauma in their childhood. They just engage in treatment lower, they relapse higher, and they have higher levels of aggression or hyperarousal, avoidance, and re-experiencing. Think of what they've been through. Lots of trauma as a kid and very poor executive functioning skills to deal with that trauma. So avoiding people is a healthier choice. This is a short list of some of the sources of stress that we see in clients who are trying to treat both substance use and mental health issues. They're dealing with all kinds of stress. Very important to understand that stress increases the hormone cortisol, which dampens the effect of dopamine in the system. And if you don't have enough dopamine in the system, you're going to start craving it. I crave things like carbs when I'm having a bad day. But when I was using drugs and alcohol, I craved drugs and alcohol. Now that I'm sober, that's off the table for me. So sometimes I'll call my husband and say, honey, can we have Papa's for dinner? And he'll go, oh, honey, did you have a bad day? Like he knows what my comfort food is, right? But when I'm stressed, my cortisol's dampening the dopamine and I start craving dopamine. So we got to remember that we have to teach clients who have mental health and substance use disorders how to deal with stress, because their chances of relapsing are extremely high when they are stressed. So let's talk about prevention and recovery. This looks like creating new long strings of neurons for healthier ways of thinking, feeling, and acting. And that's why we got to train our clinicians and our frontline workers on what these executive functioning skills are. When we get somebody clean and sober and put them on Prozac and send them back out into the world without some of these basic EF skills or these higher level skills, we are setting them up for failure. So being able to understand these and going back to basics and teaching them what this means is critical. We also need to get genetic testing, which is easily available and it's not very expensive. And so the genetic addiction risk score is something that I've done about 4 or 5 years ago. Now I got my GAR score read. And basically, if you know that you have addiction anywhere in your family, you can get your GAR score, which tells you out of 30,000 genes, there are about 2,200 of them that are linked to mental health and addiction issues. You can find out how many of those you have. I have a large amount of those, but what I love about my GAR score is it told me which neurotransmitters my brain is low in, and it gave me some suggestions for natural supplements that I could take to increase those levels. I found out that almost all of my dopamine receptors, my dopamine types are low. That means my genes tell my body to make less dopamine, which means that I'm going to crave things more often. If we know somebody's genetics, it gives us so much more information regarding how to treat them, what meds to give, and what medication not to give. And it also gives us our genetic risk for mental health disorders as well, because genetically, substance use disorders, non-substance use disorders, impulse control, personality disorders, and anxiety disorders are linked genetically to low neurotransmitter types. And this can tell us diagnostically what our genes predispose us for. So I do a lot of the GARS score testing, and the company is right here at the bottom, Genus Health, where you can order that with families who are in recovery and who want to learn what their kids' genetics look like so they can plan their prevention programming accordingly. Then lastly, we need to be able to trust the process. It's a long process, and our government and our healthcare system is not set up to pay for this process as long as it needs to be. Look at relapse rates at 9 months. They're still at 70%. We see at 1 year relapse rates for substance use, and especially for people who have co-occurring, they're about 50%. And so we see a big drop in percentage around the 18-month mark. Our relapse rates drop to the 20th and 30th percentile. And then when we get to about 5 years, we're still at about a 15% risk of relapse, which I love to know that about me. Even though I've been sober for 31 years, I need to know that I still have a high percentage, even relatively, that I could relapse. So I need to continue working a program and making sure that I don't drink or use substances. Okay, if you would like a copy of my slides, I'd love to share them with you so that you have my references. And also, if you'd like to directly email me a question, you're absolutely welcome to, because I think I'm out of time. I don't know if we have time for questions, but the link for my book is actually in the chat. Is anybody would like to ask a question before I go?
Yes, excellent. Thank you so much, Ms. Collier. I would love if you could just flash your references screen just for a moment. Thank you so much for offering to send the presentation to us.
Thank you. Yes, good.
God bless. Blessings.
Mr. Collier, this is Ashwani from Prairie View.
Hello.
Hey, I want, first of all, thank you. It was a great presentation, very, very interesting, and I came to know a lot of things. So I had a question, and it's basically a dilemma that occasional, drinker, suppose somebody takes an occasional substance and somebody is, like habituated, they're taking every day, or, they're dependent on that. Is there any difference between, how the mental growth takes place for both?
Well, sure. I mean, it's a continuum. So there are 11 symptoms of addiction. And if you meet 1 to 3 of those, you qualify for a mild substance use disorder, 4 to 6 moderate, and over 6 a severe. So it's definitely a continuum, and each substance is different. So you may have people who use one or multiple substances, and that can actually create addiction sooner or even more severe. And so, alcohol is interesting because we have a liver that can help process the toxin out before it potentially can become addictive within our brain. But things like marijuana, the more and more potent for today, stay in our system longer. And even though the symptoms of addiction are milder, we're seeing them grow in extremity. So you've got to make sure that you have somebody who is an expert in assessing substance use issues so that you can accurately give a diagnosis and a treatment plan. So I got a question. Hey, Carla, it's so good to see you. Thank you for asking me to be on this today. What recommendations do you have for clinicals working with clients during the pandemic? Back to basics, central nervous system calming, lots of meditation, guided imagery, walking. My colleague we're right across from Memorial Park, and he's doing therapy walks in the park. really back to basic on calming your central nervous system down, because chronic stress from cortisol is wreaking havoc in our adults and children alike. Also, the isolation is pretty difficult too. So Sabrina says, excellent. Thank you very much. Addiction is truly a brain disease, and we do need to continue to educate and be aware, but also train our clinicians and our community about what to look for and how to protect your brain. So thank you guys so much for having me. It's been an honor to be with you guys today. Please let me know if I can be of any further assistance.
Well, certainly, I thank you, Dr. Collier, and all I can say is one word is wow. What a marvelous presentation. I know I learned something, and I probably can speak unilaterally for most of the participants on this Zoom. If there are any questions that you would have related to this, that you think about to the audience, when we get back into the other room, you can actually put them in the chat box, and we'll get answers and get them out to you. Again, this presentation or this Zoom meeting is being recorded, and the link will be shared with you post the meeting. So at this time, we will go on break, and this time, Ash, I think I got it right, we can go back to the original room for the closeout presentation. Thank you all. Stay safe and have a wonderful rest of the day, but we ask you to join us here in about 15 minutes in the other room. Thank you so much.
But if you are a counselor or a therapist or a pastor or a faith leader or a mom or a dad, you're going to hear about someone's trauma. But if you are a counselor, a therapist, or you didn't sign up for, a faith leader, or a mom or and just because they turn 20 and 24 and 26, it doesn't stop. They still know your phone number and they track you down to tell you things like their car was vandalized on yesterday. Oh, I'm sorry, that's my story. But other sources of compassion fatigue could be could bring on higher levels of helplessness and really not having the same supports that you used to have. But if you are, so if you were one that relied on your extended family, it doesn't stop. They still know your phone number, or neighbors, or some of the networks like the car was vandalized with your church. Oh, I'm sorry, that's my story. Sister network, and they're not meeting anymore. Things are shut down because of the virus. Things were beginning to open up, and now they're shutting down again because the numbers are going up. Then we've lost some of those networks and supports that we counted on, for our own. As much as I used to complain about my sister saying, let's go for a walk for 3 miles in the morning, I really miss that now. All right, let's go to our next one. So we know that self-care is important, right? But how do we do it? How do we fit it in? It's already, I work from sun up to sundown. I'm on Zoom all day and then I get to my real work. So what can I do? What can we do? Well, so there are some things or strategies you can do to control your internal environment and your external environment, right? So there's, and I'm going to really get to that external environment because that's the area that we think we have the least amount of control. And I kind of think the opposite of that. My self-discipline indicator is usually pretty low. I have to remind myself. But the first thing that you might want to consider is something called mindfulness, increasing awareness of burnout and compassion fatigue. And I'm gonna tell you right now, I'm the person that if I try to pray or practice mindfulness or deep breathing, 1,500 things pop into my head. I don't know if you've got that problem, okay? So mindfulness is a struggle for me. So for those who can do it, and practice the first thing that you might want to consider on your phone to help carry you through a mindfulness activity. But what I did, I joined a mind and body support group, a national support group online. I Googled mind and body online support group. It popped up. It's an 8-week support group, and it just helped me develop the practice of mindfulness. I was having surgery and I thought, I need to really be intentional about my self-care. What can I do? And I looked on anyway, we'll get into that. The second thing is taking care of your physical health. All right. And some of you already do this. You run 3 miles a day and you watch what you eat and okay, so that wasn't me. So what if you're like me and this is a struggle? Okay, I fired the yard man. I asked him to do the yard one more time in a teaching kind of way, kind of show me what to do. Now, I haven't started yet, but because he just showed me his last time. But yeah, so that's my thing. So there were 2 things I paid for. I paid for people to wash my car and I paid for people to cut my yard. And so I feel like that's physical. So just try to wrap your head around some physical activity that you think you can do for you. We'll see how it goes for me, but with you, be sure to take care of your physical health and your sleep hygiene. All right, the third thing is stress and anxiety strategies, right? And this is like deep breathing, progressive muscle relaxation, body scan, especially when I go to sleep, rest your feet, rest your legs, rest your arms, rest your torso, that's a body scan, checking in with the whole body. But if these are all foreign to you, okay, you've never heard of any of this before, or you're like my husband and you call it mumbo jumbo, then I encourage you to go to this website with Kristen Neff. selfcompassion.org. She has all of these strategies on how to do all of the interventions related to controlling your internal environment. And it's no problem looking for help, because here's the thing: if you don't begin to address your own self-care as we do this really important work, then we crash, and all the people that were depending on us don't have us, right? Because we've crashed. And then who's going to pick us up? So I'm hoping that as we are coming to the end of this roundtable, we try to stick our own mental health in there somewhere. All right, let's look at external environment now. All right, so this is something that I thought would be hard for me to do. I'm kind of your yes person. I say yes all the time. But one of the things we can do to take care of our external environment in a self-caring way is learn how to say no. I know, right? But once I started, it got easier and easier to do. Become good at disappointing others, And so I start off with the yes, but, just now I'm in this roundtable and I've been listening to the breakout sessions, and someone asked me real quick to hop away on a meeting, and I said, sure, but you know what? I'm in a conference today, and I'm so glad I'm here. But before, I would have had 2 laptops open and my phone trying to do everything all at one time. It's here to do. Dividing the brain up good like at disappointing. It's just not a good activity. Another strategy would be to schedule your activities. Set up a schedule, just like you set up a schedule for kids, set up a schedule for you. I created a whole new Google Calendar with reminders and everything. Time to work, a time for play, other activities. I don't know if you're a pencil and paper person or a digital person, but there's all kind of calendars you can use, and blame it on the calendar. When the no brain divisions. Right. You divide the brain and it turns into mush. There's a whole bit of research on that, by the way. But you can set a reminder on your phone, and when your phone vibrates, I do this number. Oh, I've got to take this. And really it's nothing but a reminder that I need to be doing something else. I'm telling you. You can get around the external things that take away your self-care. Let's go to the next slide. Also break down, they call this task analysis and micro task analysis, but divide your task into smaller tasks and schedule time to work on them. And if you don't finish, give yourself a break. I like to be organized. I like everything to be neat and just where I need it to be. And a task that used to take laundry. Okay, let's go ahead and tell them myself. It was a task that only took 1 day pre-corona. Just now, it took me 3 days, but I was kind to myself. Be kind to yourself. Wash 1 day, dry another day, fold another day, put up everything another day. Use calendars to plan tasks for bigger projects. It says here like your thesis, but pad yourself time. We turn in grants. I work for a large nonprofit, non-integrated Houston. We collaborate as a team on grant proposals. I put, if the deadline internally for the team is 1 day, I set myself 3 or 4 days before that, and then break down the time. That way, if I blow it, which I might, then I still have more time built in just for me. So use your calendars, use your time, and then forgive yourself, and then plan for when you think you're not going to make it. So I know I'm not going to make the deadline because I get anxious. And I'm already anxious, and then the world is anxious. So I give myself even more stopping points. And then keep track. Create lists to manage your tasks. My dad used to say, a short pencil is better than a long memory. Why? Those brain divisions again. When you try to keep everything right here, you're overloading your executive functioning. Put it down, put it on a piece of paper so you don't have to keep everything at the front of your mind. because so many things can divide us now. There's so many distractions. And then there's this underlying, sense of concern and worry. And we talk about the people we serve, but I'm really talking about us on this call. We manage a lot of important tasks, but we're not exempt from what's going on in the world. So keep track, manage your tasks, set time frames, and reward yourself. And then come up with creative new things you can do to reward yourself. Before moving here, I bought myself at a resale shop a picnic table that I put on my patio just so I could sit outside and listen to nothing at night. And then, of course, I moved over here. So now I got to go get another table. But the point is find something that maybe you've never done before and considered that, a reward and incorporate it into your system, into your framework. Next slide. And I love, this is kind of one of my favorite right here. Create a work environment and even a home environment that works for you. Schedule tasks at times when you're the most productive. For me, that's in the morning, so you just got me. Silence or music. I'm the silent variety. I don't like any background noise. The 50-10 rule, work for 50 minutes and then do something else for 10. Now, most healthy people who really get that exercise in, they go walk for 10 minutes. I don't do that. I do crossword puzzles. So for 10 minutes of every hour, I'm either doing a crossword puzzle or some sort of find a word. I don't know, those little puzzles. And then find you a working buddy, someone to remind you that it's time for lunch or time to take a break. Because if you don't, you'll stay in your regular routine. Changing your routine is really not difficult, but staying, consistent in that change is where the difficulty comes. So, find somebody who loves to take breaks and say, look, the next time you go on a break, come get me or call me or text me. Or, if you're working remotely, they may not be able to stop by your office, right? So have a working buddy to help remind you of these things. And I'm going to add one more thing to this slide, and that is the sensory of smell, so all of your senses really have an impact on your mood, right? We learned earlier when we were talking about food and nutrition, how food impacts your mood, the quality of your food. I have never been so focused on the quality of my food. Fast food restaurants have lost me because the quality and what you eat impacts your mood, but so does what you smell. And so anyway, just kind of look at some of the information on how scents create certain moods. No, I don't buy essential oils, but I do incorporate like an air freshener or one of those plug-ins, and it just elevates my mood when I smell something familiar that takes me to a happy place in my mind. Okay, I said it, a happy place in my mind. All right, I'm ready for the next slide. All right, so here's the charge. We've got to do this. For me, it was a significant health surgery that I had that really, really made me stop and focus on self-care. And I actually I brought it just to show you. I was sitting at my table, and all I had was an envelope. You know how they send you junk mail? And I just started writing all the things that would, and I kind of hold it, not because I use it to read off of, but I hold it as a reminder that I stopped at some point in time of the rat race that I was in and focused on my own self-care and made a list of the things I appreciated and the things that I felt that I could incorporate. I love what this PowerPoint is doing. This is great. But I'm going to ask you now. I don't care what you pick up. For me, it was a American Express envelope. It doesn't matter what you pick up. We can go to the next one. Let's just get started today on transferring some ideas that you know about self-care that you can insert into your everyday life. Don't try to do it all. I can tell you right now, there's some things on this list I still don't do. But start small and just as you take on one, and then I thought I would love journaling every day, and I must have 5 journals. Well, I've started writing in each one. Matter of fact, I had different journals for different things, and now I've cross-pollinated. I'm writing down prayers in this one and gratitude in that one. Okay, it doesn't matter. It doesn't matter. Do what feels comfortable to you, and don't get frustrated with yourself if you start something and you find that it's not your thing. Practice mindfulness if you do feel guilty, right? Mindfulness for me, is asking myself, how do I feel and what do I need? Whenever I get angry, frustrated, panicked, super duper anxious, whatever it is, any kind of feeling I don't like, I stop as a matter of discipline and ask myself, what do you feel and what do you need? And work really hard to come up with a feeling word, because I like to just say mad, right? And that is a feeling, but why am I, so get down to the most basic feeling you feel, and then assess, what do you need? And honestly, that turns around my most extreme feelings, including guilt. And then make a plan and stick to it. At least try to stick to it for a week or 2. Honestly, if it's something that you thought you'd like because other people liked it and you don't, quit, right? So I already know, no matter how many running shoes I buy, running is not my thing. So I walk, and I'm okay with the fact that I walk. So it's okay to be you. But when you try to incorporate new things into your routine, do not be overly enthusiastic. Guilt is just, it drains you. It's the opposite of what we're trying to accomplish. So the way you don't feel guilty is assess, how do you feel, and then what do you need, and you'll unravel that guilt. And then treat your self-care plan. Don't treat your self-care plan as less important. Now, this is where that battery came up. You remember the picture of that I asked you to imagine, of the battery cell that's dead? What do you do when your battery cell is dead? Do you say, oh, I'm not going to worry about it, I've got time, and keep working on your laptop? Do you say, oh, you're in this important phone call, and you're going to say, well, I'm just going to chance it and see if I make it through the call without plugging my phone up? No, you run. I mean, and if you're driving, heaven help you, because you're really trying to get it plugged. If everybody was looking at me, I'd see some heads nodding. You run to get that that charger or that cord, right? Well, that's how I want you to see your own self-care, not as the glass that's almost empty, but as the battery that's going dead, because that's what's happening to us. Our batteries are going dead. Let's get to the next slide. So here's the homework for today. Identify 2 self-care activities you can start today. Something different, something new, something that you don't say, oh, I do that anyway, right? Because if you do that anyway, then that's not really special, right? So if you already run 3 miles a day, and that is for self-care, and that's great, keep it up, don't stop. But think of 2 new things you can do to add to your toolkit. Schedule them in your day and plan ahead. You already know what's going to happen if you don't think of the barriers that are going to pop up. So think of what you can do to stop it from happening. So one of the things I do for self-care is I don't talk on the phone in the car anymore. Yeah, that means a lot of people can't get in touch with me. So what I do is I actually turn the phone off and I put the phone in the back of the car. Why? Because if I hear it ring, I'm going to get too antsy thinking, who is it, right? Worst case scenario, I'm going to start reaching for that phone, even though I can't reach it while I'm driving. So yeah, I turn it off and I put it in the back of my car. And now I have such wonderful thoughts on the way home every day. We can go to the next slide. I wanted to say a little bit about what I do in my day job. So I work for NAMI. NAMI is the National Alliance on Mental Illness, right? And we've heard the stats today about the people who are really struggling. I mean, they were struggling before the pandemic. They're really struggling now, whether they tell you or not, right? So one of the things that NAMI was created for was to help the caregiver. So that's our number one client, the caregiver, the people who take care of others who are dealing with a mental health problem or a mental health condition. And the research on this is voluminous. I mean, if you ever look at it, the number one person that is in crisis is really the caregiver. You would think it's the person with the condition. No, it's people like me and you who are taking care of others, right? We are the people that are in the real crisis. And so what we offer through NAMI are free classes, free presentations, and free support groups. I just launched, let's see how many, I don't know, maybe 5 or 6 classes just during the holidays, right? Because children are going to be out of school, people are going to be off work, and guess what? And they may not be going to the malls and the stores and the things that they normally do to get away from each other. They're all going to be in the house. Okay. And what we've seen through the statistics that are out, domestic violence is going up, depression is going up, suicide is going up among our children. So educating yourself is really the best, I don't want to say remedy, because mental health conditions, they can be temporary, they can be permanent. You can take your medication or have an intervention because it's a low-grade dysthymia or something, and then you're not heavily impacted, and so you go on the rest of your life. As long as you manage it, you're not really. But some people don't have it. Some people have pretty severe stuff, and then the people who love them live with them. So find coping skills, learn strategies, and recruit help. The number one thing you can do is not try to do this alone. So I just wanted to put a plug in about those free resources. And now, because of the pandemic, all of our programs are virtual. So all of our support groups are virtual, all of our classes are virtual, and we provide these resources to different populations like veterans, military families, adult family members of adults, family members of children, and then of course the people themselves who are diagnosed, those who are seeking recovery. So all of these classes, if you go to our website, and I guess I should have put it on here, NAMIGreaterHouston.org. But all of these services are listed on our website in English and Spanish. And I guess the biggest thing we have is the warm line. So let's say you find yourself, you come across a person who is struggling with their mental health for the very first time. They don't even know where to go. They don't even know. Can you go to this next slide? I think it's my last one. You can call our number, 970-4419. Right now, because our calls have gone up so much, all of our calls are forwarded to our warm line. We have what's called a warm line. So I just found out the other day that everybody doesn't know what a warm line. So there's a crisis line, a hotline that you call if you're suicidal or homicidal, or you're in extreme crisis. There's something that you really need the police, the ambulance, and the fire department for. That's a crisis line, right? But a warm line is you're not in crisis, but you can't dig your way out. It's not going well. You're having thoughts, or someone's having erratic behavior in your house and you can't correct it. Every time you say something, they fly off. You don't really know what it is, but it's unmanageable, and you need more support. Understand that isolation will defeat you. It breeds guilt and shame and blame. And so NAMI's here through a warm line. We have people on the phones 9 to 5, Monday through Friday, and you're welcome. You're welcome. They're free to the public. Like, for instance, if we were partnering with an agency and the agency wanted groups, then we would say, okay, this is how much they cost. But if you're an individual or a family member and you want to participate in any of this, it's free. There's no charge. Okay, so someone did talk about technology, but listen, I just talked to, I don't know how old she was. I had someone call me and say, I don't have a computer and I can't join your class. And I said, okay, are you on a cell phone? And she said, yes, I'm on a cell phone. I said, is it the flipping kind or is it the flat one, just a smartphone? And she said, oh, it's a smartphone. I said, I'm going to text you something, right? And so I text her a link and I said, now, if you just push on that link, my face should pop up. and it did. And so, we worked it out. So of course, yes, we will do technology coaching, training. And I just found out today, at least where I live, there's a huge grant now for technology to be spread to a lot of different populations, seniors, people with disabilities. Just if you ask for it, they'll send you a tablet or a smartphone. So yes, we will coach people through that process. But I think this is the end of my. Is there one more slide, Ruby? I don't think so. I think this is it. Oh yeah, you can go back to the one before. Yeah, you can leave the phone number up on the one before. Yeah. So that's the end of my presentation. I think there's a lot of it there that we probably know, but one of the things I like to do is turn the focus back on us, right? Because without helpers like those in this session, like we are, if we don't take care of ourselves, then who's going to help? Who's going to be the helpers? So that's something that I really am passionate about, talking to the people who help others.
Thank you, Mrs. Hudson. And I want to, just before we adjourn, I wanted to give a few minutes to a young lady that I'm thoroughly impressed by. Her name is Grace Kelly. And Grace Kelly is actually a high school student at Lamar Academy with McAllen High School. And she has an organization called Cope with Hope that intertwines her passions for neuroscience and art through the central idea of mental health advocacy. So I wanted to give her a few minutes to talk about her program and also show a brief video. So Grace.
Hi everyone, my name is Grace Kelly. As she said, I'm a senior at IB at Lamar Academy in McAllen, Texas. And I'm extremely passionate about neuroscience and art, and primarily their applications to each other. So I've enforced community projects that intertwine these two passions in order to unite my community amidst the chaos of the coronavirus, living in a global pandemic. But prior to that, I also engaged art therapy organizations and art therapy acts, along with installations of my pieces at schools. It all started with, actually, I created a design that stimulates relaxation through incorporating the shapes and colors that transmit tranquility. And that was initially installed at IB at Lamar Academy. And then from there, I branched off into my Cope with Hope organization. I'm pretty sure she attached the link to my Cope with Hope website in the chat. And in that chat, or in that link, however, you'll see my community projects. I have also developed my portfolio of all of my art that incorporates neuroscience and obviously my applications to art, and all of them incorporate the central idea of mental health. And then further then, you'll see my Cope with Hope action tab. Through this video that I'm about to present, I kind of created a challenge. I created a challenge where I taught ways for individual community projects to escape into their own imagination by utilizing art therapy. And I motivated viewers to partake in almost this social challenge through drawing a circle that incorporates many of these shapes and colors that you'll soon learn as I present in the video. So on the website, you'll see many of my submissions. I got over 300 unique creations, primarily from Wilson Elementary and Morris Middle School, but also just community leaders and individuals. And then I also worked with the Boys and Girls Club of McAllen to enact acts of art therapy. So they were live lessons of hands-on imaginative crafts in order to foster mental well-being. And so I began to dive once again into the similar research of my Cope with Hope circle projects. And then I also have worked with a local author to create a children's book titled Squish that's currently in the process of publication. And the book centralizes to around mental health, but kind of is more of a children's book and utilizes the character of Sorry, I got kicked out really fast. Utilizes the character of Squish, who is an octopus, to kind of illustrate the many ways one may learn to cope with hope. The whole premise of my organization. So without further ado, I think Ruby was going to show my video.
Hi everyone, my name is Grace Kelly. I'm a junior in the IB program at Lamar Academy in McAllen ISD. If you're like me, these tough times in quarantine can bring some unwanted anxieties. Through a series of videos highlighting my passions for neurology and art, I hope to break down unique and creative ways for you to cope with hope. Let's get started! Today we'll be starting with the basics of drawing that will help you relieve your anxiety. I encourage you to use any materials you have at home: crayons, pencils, pens, or even pastels. I will be working with crayons and selecting the colors green, pink, blue, and yellow because these colors symbolize clarity and freshness through times of stress. We will first be starting with the basis of drawing a circle, as curved shapes symbolize rhythm and movement and allow one to access the happiness and pleasure within their mind. We will also be incorporating a variety of curved shapes, including spirals, to represent creativity found within the natural pattern of organisms, shown through strength, growth, and evolution. Let me let you in on a little artistic secret. Everyone can draw. Using your materials, I motivate you to use this time with your family to escape into your unique imagination and explore all of your inner thoughts. In this basis of the circle, feel free to allow your mind to be at peace by drawing any thought that comes to you. Through art therapy, you're not only lessening stress in the body, but are too producing a beautiful piece of art that highlights your creativity. Remember, this is not for a grade or any form of competition, but is simply a way for you to relieve all of your built-up anxieties. I also encourage everyone to take some time out of their day for a little self-care, even you, Mom and Dad. Everyone should make time in their day to let their mind feel at peace by putting all of your worries and thoughts on paper. If you don't have any materials at home, I hope that you still take the time to close your eyes and fill your head with positivity by dreaming of the flow of nature. As you can see, I'm letting my mind take control of my drawing by getting in touch with my feelings and doodling a variety of curved shapes to clear my head. Similar to meditation, drawing curved shapes transmits a sense of flow that can reduce your stress levels by serving as an abstract representation of what is stressing you out and expressing your true inner emotions. I cannot wait to see everyone's individual circles. No matter how your piece turns out, it is special because it was made by you. Once you feel relaxed and have filled your circle, reflect on this state of mind and be hopeful for the future. Don't forget to continue to cope with hope and start with art. I hope you enjoyed the video. Stay tuned for tomorrow's episode where we continue taking care of our mental health together. Make sure to hashtag your post participating in the challenge with hashtag Cope with Hope and tag my Instagram, Grace Cal Art, along with McAllen ISD. See you soon. Hi.
Thank you, Grace. On that note, I would like to officially conclude today's event. I want to thank everyone for joining us today, as well as thanking all our speakers and presenters. I hope that everyone found the information presented today helpful, but we will be following up with links to the recordings of today's session, as well as resources. But again, I appreciate everyone for participating today. Thank you and have a great afternoon.
Thank you.